Good morning, everyone. How are you? Good, nice. Good morning, everyone online. I think we have about 90 people maybe online, and we have a wonderful crowd here in Flagstaff. So thank you all for coming. We really appreciate it. So good morning. My name is Samantha Sabo. I'm an associate professor here at NAU in health sciences. So I'm pure public health. Who do we have public health in the room? Right, public health. And I'm a researcher with the Center for Health Equity Research here as well. So I'm based here in Flagstaff. And if you don't know me, and I know so many people in the room, I'm really into community health workers and community health representatives and promotores de salud, as you all are, right? Yeah. So we got to get into that spirit, right? The spirit of community health workers, lots of good feelings and smiles and clapping and motivation, right? Motivation for all of us. It's good to see you. So before we find out who's in the room, so get ready, onliners. We might ask you to take your video off so we can just see you briefly before we start. I wanted to just go ahead and thank just express my gratitude for all of the people that made this happen. So first, I'm truly grateful to the Arizona Community Health Worker Association and the Arizona Advisory Council on American Indian Healthcare. They are our co-sponsors for today. So thank you, Kim and Flor. Woohoo! Both are long-term partners to many of us in this room. And so we're so grateful for their partnership in co-hosting today. Next, I'd like to thank Drs. Steve Palmer and Bob Trotter, who lead the Arizona Department of Health Arizona Biomedical Research Center grant. So the money, who supports this event today. And so today's workshop is one of many workshops that NAU Center for Health Equity Research will host with community partners throughout the state, and past and upcoming workshops are listed in your programs. So be sure to check those out. And they're all going to be recorded as well. So if you missed some, we will have those up for you. Next, I'd like to thank our incredible support staff, Nick Beckett, Bree Bullard, Taylor Lane, Marcel Coder, Lisa Dom, and our awesome AV team, which is over there, who will make it so we can see each other, hear each other, and hopefully have an interactive experience throughout the day. Because of these amazing people and their expertise, we have a great turnout. So as I mentioned, there's about 90 people maybe online, and there's probably 70 of you here in the room, which is wonderful. We will have a yummy lunch, which is exciting, and the ability, as I mentioned, to record the event. So in case you would like to think about what people said in your own time and share the information that you hear today, we'll be able to have that recording available to you. Finally, I'm truly grateful for the presenters and the moderators who have joined us from all over Arizona to share their innovative work with us and how they support the CHW workforce and integrate CHWs into health and social teams to serve all Arizonans. You can find their extensive bios and contact information for all of our speakers and moderators in your program. And we really invite you to read about them, and we've put in they allowed us to give you their emails. And so we encourage you to contact them if you are inspired by anything that anyone says. So the spirit of this workshop is really about unity. We're in such an incredibly exciting time in the community health worker workforce trajectory, which has been going on for many, many years, with the oldest CHW program having been funded in 1961, and that is the National Indian Health Service Community Health Representative Program. Do I have any CHRs in the room? Woohoo! All right, probably online. So we've been at this for a long time, and we're in a really particular place at a particular time where CHWs have come to the forefront, serving the needs of Arizona's most vulnerable populations in the time of COVID, a global pandemic, but they had been doing that work for years in the state. And so we're so excited to celebrate them and to learn how each of us all can play a role in growing this important workforce and sustaining this workforce in the times to come. So we really appreciate you all being here. Without further ado, I'm gonna hand it over. We are going to have a wonderful program which involves kind of 3 main sessions. And if you check out your agenda here, you can kind of see what's going to happen. We have wonderful presentations from our first set of panelists, our state and federal partners, which will be moderated by Kim Russell of the Advisory Council. And then we'll break for a delicious lunch, and that will be served back in the back area. There is coffee out there now, so the food will be there, and you're welcome to come back to your chairs, enjoy each other, think about what you heard from our state and federal partners, and how we can leverage all of the wonderful momentum that is going on there. And then we'll come back in the afternoon to listen to 4 distinct programs serving rural, tribal, border, and urban communities. These are people that have been at it a while, really thinking and working out the kinks of integrating community health workers and CHRs and promotores into clinical care teams, as well as social care teams, to really address the social determinants of health. So we'll learn from them, and you have all their emails, so you can contact them for advice, and they are so willing to give it. And so we're hopeful for that. And then we'll end our day really listening to the workforce and the prominent allies that have been supportive of this workforce for many years. So we'll hear from our Association of Community Health Workers. We'll also hear from our CHR movement, so our community health representative movement members, as well as other allies that have been in the race for a while. So thank you very much, and I appreciate you all coming, and I will ask him to join us, as well as the panelists from ADHS and Access. You all can take your positions here, and we'll get started with the presentation.
Good morning, everybody. I'm happy to be here. I appreciate the invitation to be the moderator for this part of our morning with the power and promise of CHW voluntary certification in Arizona. As Sam mentioned earlier, we are going to hear from state and federal partners. We really encourage you to please be an active participant and throughout the whole day. This is an opportunity for all of us to ask questions of our distinguished panel, and we'll be able to do that all day. Again, let me introduce myself really quickly. My name is Kim Russell. I'm the director for the Arizona Advisory Council on Indian Healthcare. I've been a part of the agency for about 8 years now. Love working with CHRs. I think I've been working with them ever since I started at the Advisory Council. Maya and Jill, and I believe Sam, had approached me about 8 years ago and said, how do we work with CHRs more? And my first question is, what's a CHR? I didn't even know what a CHR was, but through those years, we've done a lot together. So I'm really happy that we're coming together to talk about this juncture in the movement of CHWs and CHRs. I'm from Chinle, Arizona, on the Navajo Reservation. I'm of the Bitterwater people, born for the Tangle people. My maternal grandfathers are of the Coyote Pass people, and my paternal grandfathers are of the Bitterwater people. That's who I am as a Navajo woman. So I'm going to go ahead and introduce our panelists today. Like I mentioned, they are our state and federal partners. So we have guests coming in from the state Arizona Department of Health Services, and that's Karen Watts, Health Disparities Program Manager. She'll be providing our first presentation. Please refer to your program here to read a little bit more about them. If I were to introduce them, I'd be here for quite a while. Next, after Karen, will be our federal partners at the Indian Health Service. And that'll be Michelle Archuleta, Public Health Advisor, Community Health Team Lead, and CHR Consultant. And she'll be joined by Loretta Haven, who's a PHN CHR Consultant at the IHS Phoenix area office. And then following our federal IHS partners will be our state Arizona Healthcare and Cost Containment System partners. We are joined by Leslie Short, who is here with us today in person. And she is Integrated Services Administrator of the Division of Fee for Service Management. And then also Alex Demian, Deputy Assistant Director. We are joined by Amanda Bahi, who is the Tribal Liaison for the Arizona Healthcare Cost Containment System, and Jay Dunkelberger, who's the Network Administrator, and they will be joining us via Zoom. So I'm going to go ahead and stop there and invite our first presenter, Ms. Karen Watts, who's going to come up and provide her presentation. Then we'll go to IHS, who's going to be online, and then our Access presenters. Karen?
Thank you, Kim, for that warm welcome. Hello, everyone. I'm Karen Watts. I'm the Health Disparities Program Manager at the Arizona Department of Health Services on the Bureau of Chronic Disease and Health Promotion. Today, I'm going to be covering a little bit about just the Arizona CHW voluntary certification, the history of certification in Arizona, and the status of where we are. So it was a little bit about the benefits as far as ADHS perspective of the benefits of certification, and then a little bit about the sustainability of the workforce and how certification plays into that sustainability plan. I have my extensive notes here on the history because a lot of the history happened before I joined ADHS in 2020. So dates back to 2013, actually. Oh, I'm sorry, I'm not progressing for you. There you go. Now you can see what I'm saying. So for the history, things kind of started off in 2013 with certification for CHW voluntary certification. So in 2014, ADHS hired their first CHW program manager, Yanitza, who you were all, most of you are familiar with. My predecessor in this role, that role was dedicated to just bringing general awareness and advocacy for the CHW workforce, including advocacy for CHW voluntary certification efforts. So this is the first time we had a program manager within our chronic disease team that was focused on that workforce and advocacy for the workforce and working with the various different partners to build upon that. In 2015, that's when things really kind of started off. In 2015, 2016, meetings with the Democratic Center to discuss the sustainability of CHWs and certification. And then building consensus around just the general population of the CHW workforce, as well as the partners that were engaging with this workforce as well too. And then just moving into having further discussions about the benefits or the potential of having CHW voluntary certification in the state of Arizona. So then in 2017, ASCHO held a meeting, an emergency meeting to discuss pursuing legislation for CHW voluntary certification. And that's where kind of a lot of the advocacy for that piece came in. They met with, Democratic representatives to kind of help sponsor that bill, to move the bill along. The bill passed out of the House of Representatives, while the coalition members were still for the CHW Workforce Coalition and other work groups working towards, discussing CHW voluntary certification with the opposition of the bill. And then came in 2018, after this long road of 5 years of discussing certification, the Republican representative and chair of the Health Committee sponsored the bill and moved the bill forward. And so the bill passed through the Senate and the House. And on May 16th, Governor Ducey signed the bill, the House Bill 2324 into law. And that established ADHS as the certifying body for voluntary certification in the state of Arizona. That's 4 years as of today that this law was passed. So a lot of slow movement since then, obviously 4 years. The rulemaking process has certainly been a much lengthier process than any of us had hoped. Again, I came kind of new into it. I came right into 2020 when we were just starting the rulemaking process. But prior to that, the first part of the statute was to have our director at the time convene a CHW advisory council. And that council that consisted of 9 members, and those members were representatives of CHRs or CHWs. They were, employers of CHR, CHWs, as well as county, university, and nonprofit entities. So those 9 council members were tasked with developing recommendations for ADHS on the core competencies, the CHW core competencies that should be included in the rules, education requirements, skills, continued education requirements, and just overall some of the more detailed recommendations for how to move forward with the rulemaking process. And so in 2020, those recommendations were submitted by the advisory council I would say about a week after I started ADHS actually. And then it moved forward to our ADHS Administrative Council and Rules Department, who was put in charge of drafting the first draft and the drafts to follow. I think we have about 6 drafts out there now of the rules. So, and I'll talk a little bit about that, but there, you can view them all on the administrative rules page. Essentially, a draft would be posted. There was a 2-day public comment period. Following the public comment period, if there needed to be substantial changes made, those were made, and then it would progress into another draft and so on and so on. So here we are in 2021. Starting in 2021 into now 2022 present. We're in the final stages of the rulemaking process after 4 years. So a couple more steps to go. So far, what most recently what had happened was 30 days ago, as of the 10th, the notice of proposed rulemaking was posted to the webpage for a 30-day public comment period. So that notice of proposed rulemaking was submitted to the Secretary of State and then posted, but that closed again on May 10th. So right now, Administrative Rules Council and Rules and our licensing team, both teams are looking at the comments that were made and deciding whether they need to make any changes. As well as on the 18th, I'd be happy to have everybody join us. There's going to be an oral proceeding. If you go to the Administrative Rules page off of the ADHS page, you can see the current NPR, and in that NPR, you can see the call-in information for that oral proceeding, and that'll be a final opportunity for any public comment. Following that, and any changes being made to the draft rules, the notice of proposed or notice of final rulemaking, I apologize, will be submitted to the governor for review, and then following the governor's review, the governor's review, regulatory review council. And that will be the final step. And then whatever changes they make, or if they make any changes or maybe they decide just to move it forward the way it is, that's how the rules will be moving forward. So unless somebody is to do an amendment of any kind in the future. So we've reached the end of the road. Well, not quite. Right now, it's tentatively based off of those processes and the amount of time that each of those reviewers are given. We're looking like fall of this year, though, that certification will open up on the ADHS webpage. A lot of effort put into that, a lot of effort. I'm just briefly going over this timeline, but so much of the work was done before I joined the workforce here. And it just you can read the history of it. There's papers and just different narratives surrounding the history. And it's really just interesting to see that process, but also in a way daunting because it's been so long. It's taken so long. So next. So certification of the CHW workforce is trending in the United States. So Arizona is not the first state to pursue CHW certification. It certainly won't be the last state. This is the status of 2020. This is the most current status that I could find of where the different states are in their process. So some states, credentialing is a little different for each state. Many of the states go through their health department, as Arizona did, but others can implement it through Department of Health Services, Board of Nursing, or even a third-party entity. So you'll see just the different states and where they are with their certification process. But a lot of this goes into really looking at certification as a tool for sustainability of the workforce, and that's a national trend. So certainly Arizona, I would say, is leaps and bounds in front of many of these states as far as where we are in the certification process, but also most importantly, where we are with the workforce and how we support the workforce and the work that the workforce is doing, how established the workforce is here in the state of Arizona, how passionate the workforce is here in Arizona. We're leaps and bounds ahead of many of the other states. Myself, I was a CHW. I started my public health career as a CHW in the state of California, and there wasn't an association that supported me. There wasn't a partnership. There wasn't collaboration of any kind. We were so segregated. So to come to Arizona and just see how much passion and just empowerment is surrounding this workforce is just incredible. Incredible. And again, this is happening nationwide, and we have other states who are calling upon Arizona as an example, as a model, asking us, what are you doing? How do you engage CHWs? How do you engage CHRs? Using additional funding to engage those. And so I think that's something really to be proud of. I definitely, again, can't take credit for that. It's a lot of work that was happening before I started. And so I think there's a huge round of applause, maybe not right now so I can get through this, but that needs to be given to all of that work that happened. Okay, let's do it. You're the runner of this show, if you give me permission. So a little bit about the benefits of certification. So again, certification is really a vital tool in ensuring the sustainability of the CHW, CHR Promotora Susulud workforce. So this, there's so many different benefits, but really the major benefit is that it's just going to really professionalize or further professionalize this workforce. So there's possibilities of additional recognition for the workforce, additional compensation or compensation methods, training, and the standardization of the workforce, similar to what nurses went through. When nurses first started out in the 1800s, they were very unorganized. Many of them were volunteering. They were working in rural communities. Sound familiar? That's where they started. And then states started catching on that, oh, maybe we need to have a standard for this workforce. Maybe we need to have some type of licensure. And it wasn't until later in the 1900s, 1935, I think, was the first state that implemented a licensure. So similar to that, we're building that momentum. And certification of the workforce is certainly that vital step that's needed to build that recognition, to build that standardization of the workforce. So ADHS really believes that certification will have significant benefits for all who are involved, for hospitals or healthcare facilities or other employers, to have employees who are certified by the state health department. That means having their education, their work experience, and other documentation certified or, really verified by a state health department, backed by the state health department, in partial ways funded by the state health department. That's going to be important. That's another leading step in standardizing that workforce and promoting the recognition of the workforce. Really for patients or just for community members, there's a lot of benefit for them, in the rural remote areas where maybe there's not a lacking of access. The hopes are if we have certification, that's going to lead to more reimbursement strategies, which hopefully is going to lead into higher and equitable wages for this workforce, which means we're going to probably have more job opportunities for the workforce in these various different communities because we're going to have a way to pay the workforce, hopefully. That's the hopes, right? That's what we've all been going through all this for. And so hopefully that means more access for our community members, more resources for our community members, and more engagement of CHWs integrated in all of our public health and healthcare teams. Other benefits include just, again, increased workforce credibility, acknowledgement of the hard training and all of the experience that our CHWs, CHRs, and promotoras have put in to their communities. It's a stepping stone into furthering your education and career. It's, I know it was my pipeline into public health and moving forward with a graduate degree in public health and things like that. That's where I started. That's where my roots are, and assist in job opportunities. Again, hopefully the development of more jobs. And increased in funding and reimbursement opportunities. I think that's the most important part because we all know funding for our CHW workforce is just lacking. We try hard, we apply for grants, but many of those grants are short-term. And we have to have a method of sustaining the workforce outside of that grant funding. Of course, at ADHS, we're going to continue on to apply for grants and push out that grant funding, but we need to have additional sustainability, and certification and reimbursement is the way to go. Oh, I got to go back one. It's a collective effort to sustain this workforce. All of us are working towards that in this room in some way or another. Everyone up on the panel here is working towards that in some way or another. So it requires a team. It requires a village. It's like raising a child, right? We're raising a workforce and it's going to require that village to do so. We have national support. So we've seen an increase in funding for the CHW workforce, or rather more funding just to develop the public health workforce as a whole. But we see a national recognition that we need to be including CHWs in that public health workforce at every opportunity that we can. So we see more and more funding. We have our APHA CHW section is consistently expanding. Our NACHW, which is moving forward with their plans for sustainability. We're all involved in that. State support. So ADHS, we're consistently looking for funding opportunities so that we can continue to push out that funding to the workforce, but more importantly, to support those organizations that are supporting the workforce as well to get them funding to do the hard work that they're doing and to continue that hard work that they've been doing. We also have a movement towards Medicaid or health plan reimbursement for CHWs nationwide, which is hugely important, right? That's huge. It means that we can move outside of the grant model, not completely outside of it. We're going to continue with the grant process, of course, but it gives us another opportunity to get further funding for the workforce. And also just CHW's employers. We have more and more employers who are jumping on board to write into their grants or apply for new grants, the workforce, and further developing the workforce, further training the workforce, and further just funding the workforce for creating job opportunities. I said national support. This is only 3 of the grants that we've seen in the past year and a half that have come out to build the infrastructure of the public health workforce. And again, each one of these grants, well, one specifically was tailored towards CHWs or CHRs. The other 2 more had it written in there that we needed to include CHWs into our plans for these grants. And we have since, for our public health workforce supplemental funding grant funding, we're going to be using that to expand the CHW workforce in the way that we'll be supporting CHW fees with that funding, or tuition for CHWs to go get further training or formal training for that. Our health disparities grant, we have at least 9 or 10 partners, county partners or community-based partners who are receiving funding through that grant, who have CHWs written into that work plan, either further developing the CHWs they're already working with or hiring CHWs. It created new jobs. We've seen an influx of jobs because of the influx of this additional CDC funding or other funding sources. So state support. So ADHS, where do we come in with this? So what are we currently doing? So of course, we're always looking for opportunities to grow and expand the workforce, but also how do we further support those organizations already doing that work? How do we further build their infrastructure so they can better support the workforce? So we have different variety of grant funding that we push out that for different initiatives, including training program approval process, training and other professional opportunities with specialized trainings, CHW certification efforts. So this is even just outside of the rules and things like that. Myself and some of my team members have worked really hard to advocate for changes in the rules and advocate for, thanks for the warning, I'll get through this pretty quick. That's a good one. I didn't see your 5-minute one. I apologize. So, but also just looking at how can we further support certification fees and moving forward. And other other opportunities within the CHW community, integration of CHW strategies into our own healthy air, our Arizona Health Improvement Plan, our 5-year strategic plan. We were very, very specific to make sure that there were strategies written into those plans. So I'll talk just a little bit about future plans, and then I think I was done anyway. So then I'll hand it over to our next team. But what's ADHS going to do in the future? What does it look like for us to continue with the sustainability of CHW workforce? So again, continuing to integrate CHW workforce and those supporting organizations into our plans. Not just, and I use this often, many of you may have heard me say this in one of my updates for certification, that not pulling them out as a shiny tool that we use and put back when we want. Integrating them into our plans, and not only the planning portion, but the implementation of the plans and the funding of those plans. We'll continue to identify funding opportunities to advance and develop CHWs. And we'll promote CHW certification as a vital step of ensuring the sustainability of the workforce. And then we'll advocate for reimbursement services through state Medicaid programs, Medicare programs, and other healthcare programs. We'll always be a partner in that and provide any resources we can or support we can and advocate for that. So I think that was it for me. I am going to pass it now over to, we have our Indian Health Services Community Health Representative Program with Michelle Archuleta and Loretta Haven.
Perfect, thank you. So let's see, my name, first of all, let me just say thank you for the invitation and the opportunity to be a part of this panel, to be a part of this exciting work that's happening. We're always watching what happens here in Arizona. As Karen said, you all are leading the trend with CHWs, and so we have lots to learn from all of these efforts. And so my name is Michelle Archuleta, and I'm a public health advisor for the Indian Health Service. Two roles of mine is the CHR National Consultant, and I'm the project manager for the National Health Coaching Pilot Project. I'm an enrolled member of the Lone Pine Paiute Shoshone tribe. We're a small tribe located on the eastern side of the Sierra Nevada mountain range, just right below the base of Mount Whitney in California. And so this presentation is going to be in two parts, and I have the first part. And so I'm going to be talking about the big picture perspective with IHS, the CHR program, and where we're going nationally. And then I'll have Loretta Haven, Commander Haven, she's going to pick it up and talk about how CHRs can fit into this healthcare accreditation piece. Let's see, I'm going to advance. So this is the Indian Health Service, and we are a health service delivery system where we provide direct and purchase care to American Indians and Alaska Natives. Our reach is approximately 2.6 million American Indians from 574 federally recognized tribes. And this covers 37 states. There's authority to provide healthcare services for Indian people, and this is dependent on numerous treaties, regulations, statutes that come from and include the Indian Healthcare Improvement Act. And this is important authorization that was authorized in 2010 with the Affordable Care Act. The IHS mission is to raise the physical, mental, social, and spiritual health of American Indians and Alaska Natives to the highest level. So the Indian Health Service has identified the following areas as priorities for meeting the mission of the Indian Health Service. And we see the CHR program having direct application in many of these areas, and in particular, the ones that are highlighted. So we see it with trauma-informed care. And this is especially relative to this unique lived experience that CHRs have coming from the communities that they work in. And so this is important because of the necessary peer support to ensure a cultural humility approach between the provider and the patient. So they're role models in this piece. The social determinants of health is hands down something that I feel is in the domain of CHRs, because we see over 50% of our CHR health services really support that important marker that's critical in impacting health and health outcomes. And we're going to talk a little bit more about this in the next few slides. Maternal health projects. CHRs have long understood this health priority area, especially as it relates to bonding, engagement, and development between the mother and the child, especially from birth to 3 years. And so we have a partnership with Johns Hopkins University called IHS Family Spirit, and this is where we train CHRs as family-based educators going into the home setting. Cancer prevention. We see CHRs having a very important role in decreasing stigma with colorectal cancer screening. And this is a way to contribute through our outreach around community messaging and education and that home testing component. So we see also in alignment HIV and STI efforts similar to the screening piece with cancer prevention. And then I just mentioned a little bit the Health Coach Pilot Project. Really, this is a once-in-a-lifetime opportunity for CHRs. We just launched our cohort 1 the beginning of April, where we're going to finish that in October, and then we'll recruit for cohort 2, which will start early next year in 2023. And so we have an opportunity to bring in 25 CHRs from around the United States to learn and become certified as a board certified health coach. So that's just going to have workforce development opportunities for the tribe. It's going to build capacity and knowledge in the area of patient-centered and relational approaches. But I want to just say the reason for the patient-centered care and the PCMH piece, that is going to be something that we're going to talk more about in depth with Commander Haven in the second part of this series. And so I like this definition of our CHRs. And this is actually similar. It's actually very similar to the APHA. We modify it, obviously. But where you see the difference is just a little more emphasis on community, language, and traditions. And we really think about that as related to land, to ancestors, to story, and elders. And so as I've done some work in leadership, Indigenous leadership, I keep seeing those four words, land, ancestors, story, and elders, as just being constants when we talk about healthy communities and holistic communities. So the CHR program, we're headquartered in Rockville, Maryland. We have authority under the Healthcare Improvement Act, the Snyder Act. In the beginning, it was really developed or implemented to meet four basic needs. And this was a call to action from the Indian Health Service and public health for a greater need for involvement, for participation and identification in problem solving of a person's individual health problems. It was the need for greater understanding between Indian people and the Indian Health Service system, because there was a gap there in terms of, you know, these public health and these clinic, I would say, field stations out, and how do we get patients to come in and participate in this traditional way of healthcare. And then there was the need to improve cross-cultural communication between the, I would say, Indian community and the providers of the health service. And so we've always known CHRs played a major role in this interpretation and this translation piece. And then it was the need to increase basic healthcare in homes and in communities. And that really kind of comes at the start with prevention, okay? And so as a 54-year-old workforce, you know, we have established some foundations that have contributed and benefited the field of community health workers. And we see this with CHR scope of work, with an EHR known as CHR RPMS, PCC. You know, the data mart is such a powerful, robust system that allows program managers to extract and pull out data around reports that can be drilled down individually to CHRs, to chronic diseases, to patient encounters. I mean, it has such a wonderful way to showcase the work. And then these evidence-based curriculums that we've integrated into the CHR program. And one of them was that I've mentioned, the Family Spirit program. And so this is an important slide that I think really helps showcase how CHRs impact overall health. And so we have this current focus on the social determinants, and we see how CHRs impact these socioeconomic factors and the physical environment through the use of these health services that are found within our CHR national scope of work. And you know this as the case find screen, any type of patient or health education, case management, care coordination, deliveries that CHRs are always involved in, transportation, non-emergency care, and these home safety checks. So when you think about it, and I did mention 50% of what we do as CHRs are dedicated towards supporting these social determinants that impact health. But you can also see the lower third and the fourth box on the left-hand side. We also have services where we are supporting health behaviors and where we're supporting the overall field of healthcare. And so I'm not going to go through that, but you can see that piece. And what I really kind of have found interesting because of COVID is how COVID has just exposed these health disparities that have, we've known them, we've heard them. It's now, it's like the curtains are drawn open. It's boom, it's all out there. And so I really see CHRs helping healthcare move out of its own comfort zone of being within the four walls of healthcare out into homes and into the community. So that is something that I feel very proud of, and to keep advocating on behalf of CHRs. And so this is actually the question about, well, how is IHS continuing to move with that trend where the CHW field is going? Well, in thinking about this, we're doing it in many, many different ways. We don't have the, I would say, the reach that Arizona has, or some of these other programs like New Mexico at the moment in terms of the structural support. But what you can see, what we're doing is we are, as an IHS CHR program, we're involved at the table with these HHS SDOH full group meetings. And that's important. And we have participation with these affinity priority work groups that are focused on CHWs. And I also want to see, I'm part of a, or I want to say, I'm part of a sustainable finance sub-work group out of the CHW HHS piece. And, that's important to actually help translate, well, what's happening, as Karen and others are going to say today, so that we can make sure that it gets up to the agency level. Because sometimes those arenas just don't, federal, state, local, sometimes there's misses there. And so the other way is around the lower section. It reflects, I think, where we as a national program are looking to help support and scale what's happening as CHW best practices around statewide efforts. And so them as reimbursement at the moment with Medicaid. Exciting to know that Medicare is being considered, what a scope of work is for the state, and how a CHR program within that state may need to shift or expand its own scope of work. And then looking at that certification piece. I think that's very, very critical and important. And so this last slide, this is my last slide, it represents a very large macro lens perspective of the organizational context of CHR programs that have both, I call them enabling and constraining influence on program and individual actions. And I see this, and it's this, and I think when you've been at the table, and I'm sure that Karen, in hearing what she said, in telling the history of the Arizona legislative piece, it took four long years to get to this point, but now things are speeding and it's fast. So there's context with all of this. But as you can tell, we are part of many ecosystems as national CHR programs, area CHR programs, statewide CHR programs, and all these ecosystems are interconnected and they're interdependent with high variance and high complexity. So this macro system has a wealth of experience, and all of you in the room are part of this macro system. And you reflect legacy systems, you reflect your own contributions with a program at an individual level. It could be from government, from state, from academia, nonprofits, CHW associations, tribal leadership, and the community. So that is and this is big, this is daunting, but as you can see in the background, you know, this work involves the network of this field, the energy. So networks are energy. It can be differences and it can be similarities. Okay. So now we're going to go from zooming from this macro perspective, and we're going to go into, I'm going to say, a meso perspective. And we're going to hear how opportunities can also exist for a new type of interactive space that involves CHRs integrated into the patient-centered medical home. And so with that, I'm going to hand it off, and we're going to transition out of this first part and go into part two.
But I think we lost Loretta. We're going to go ahead and transition to our state partners again, Arizona Healthcare Cost Containment System. Please come on up.
Thanks so much. Helen, Kim, this is my first in-person presentation since the pandemic. So appreciate you all being here with me, and we'll get through this together. Thanks again so much for having us. I'll be turning it over to my colleague Leslie here about halfway through our portion of the presentation, but really happy to be able to come and share some of the CHW and CHR sort of workforce work that we've been engaged in. Before I get started, we are at NAU, so I just wanted to issue a congrats to all of the recent or upcoming graduates and all of the professors and supports that helped get you there. Monumental, very, very exciting. So with that, my name is Alex Demian. I'm a Deputy Assistant Director with our Division of Community Advocacy and Intergovernmental Relations. And with that, I'll go into some of the acronyms we'll be using today. So at Access, we do live in acronym soup. So just wanted to start out by level setting. Many of these I think are going to be familiar to those in the room, but want to make sure we're all singing from the same sheet. So if you haven't heard of us, Access is the Arizona Healthcare Cost Containment System. That's Arizona's Medicaid program, if you're not familiar. Alltex, you may have also heard of. That's our Arizona long-term care system. That covers a lot of our home and community-based services. CBOs will also be speaking to that. Those are our community-based organizations that we'll be referring to, organizations that historically maybe haven't been involved in Medicaid reimbursement. And CHWs, I don't think I need, and CHRs, I probably don't need to spend too much time on, but just in case, I wanted to put these up on the screen as well. Those are our community health workers and community health representatives, respectively. So CMS, the Centers for Medicare and Medicaid Services, that is our federal oversight partners that we work with as the state Medicaid agency here in Arizona. IHS is our Indian Health Services partners. LTC you might see in the presentation as well. That's just referring to long-term care and the long-term care system. MCOs, our managed care organizations. So those are our contracted health plans that we work with and that help administer the Medicaid program here in Arizona. And then SPA, less glorious than the SPA you're probably familiar with, but those are our state plan amendments. And I'll get into what those are in a moment. So as a bit of background on Medicaid reimbursement of CHWs at the national level, in 2014, CMS changed a rule that expanded reimbursement of preventative services, which helped facilitate the possibility of reimbursement for CHW services through state Medicaid programs. After this change, other non-licensed practitioners such as CHWs can provide and be reimbursed for preventative services. So just wanted to mention a couple notes here, and they're on the screen as well, on what preventative services are as they're defined in the federal regulations. So they must be recommended by a physician or other licensed practitioner and must involve direct patient care and must directly address the physical or behavioral health needs of the patient. Lastly, hearkening back to that SPA word, in order to make CHWs reimbursable under Title 19 or Title 21, which is the federal framework that provides the authority for Medicaid reimbursement and for Medicaid more generally, states, in order to have access to that pool of reimbursement, states must submit a state plan amendment, or a SPA as we call them, that describes the education, training, or credentialing the state will require of CHWs. And it also must define the services that CHWs will provide and how they'll be reimbursed for those services. So since wanted to provide kind of a bit of a national landscape, and I think that what's going on at the national level is more expansive than what we have on the screen here. I think our colleagues at ADHS did probably maybe a little bit more, a little bit better job giving a picture of what all is going on state by state. But since that rule was changed, since CMS changed that rule, numerous states have moved forward with seeking state plan amendment or SPA approval for CHW reimbursement. A few examples here: Oregon established a patient-centered primary care home program that reimburses for CHWs. Minnesota established a CHW certification, which reimburses for education and symptom management codes. North Dakota reimburses CHWs through a targeted case management program. And South Dakota reimburses CHWs for certain services to members that meet qualifying criteria. So it really does run the gamut how these programs are set up, how CHWs are reimbursed. And this is sort of just a flavor of that. Again, this is not all encompassing. And this is sort of based on the most recent info we could find. So there may be a nuance here or there that might have changed in the evolution of each of these respective programs. So, as has been mentioned before, we at Access are very aware that the work that CHWs and CHRs do in Arizona is by no means new. We're aware that Arizona has a longstanding CHW and CHR workforce in communities and organizations across Arizona. We know that at least 5 of our contracted health plans, or those MCOs, currently utilize CHWs and utilize them for nearly the full range of CHW core competencies that exist. The health plans pay for CHWs and CHRs using administrative funds currently, but can't count those codes or those activities as medical services or submit encounters to Access, which is really what the second, I guess, part of this that we'll be talking about is, how do we develop a structure or implement a structure that does allow for that does allow for submission of codes or encounters. Lastly, before I turn it over, we do know, and it's top of mind as well, that 19 of the 22 tribes, as far as we're aware in Arizona, do employ CHRs. CHRs have traditionally been funded through the IHS system. I think this was spoken to at length in the previous presentation, so won't spend too much time there. But we do also know, based on the workforce assessment, that CHRs currently make up about 30% of the CHW workforce in Arizona. So a super crucial component of the CHR, CHW universe and delivery system. So with that, I'll go ahead and turn it over to Leslie to bring us home here. Thanks so much.
All right, thanks, Alex. So I think as Alex has kind of set up and provided some background, it's very clear that we know that Arizona has a really strong and longstanding workforce with CHWs and CHRs. And so given that, looking at that, the infrastructure that's already in place, the work that's already being done, what is that potential impact on the Access population health? I think that also this has already been touched on a little bit as well. I think Michelle Archuleta did a great job talking about how CHWs and CHRs do help with addressing health disparities. And we know that by utilizing and implementing the CHR and CHW workforce, they can be used to decrease health disparities. And this really goes abroad or stretches both into our adult system of care and also our children's system of care. We also know that CHWs and CHRs are really well positioned to reach patients in the rural settings. We know in rural settings, members often encounter additional challenges accessing care. And I think, to Alex's point previously, highlighting the roles of CHRs, that they make up 30% of the workforce, the CHW workforce here in Arizona. I think that really speaks to their stretch and the ability to reach the rural population. Also, I know I worked in Yuma for a short period at a organization there, and they implemented promotores. And I know that promotores were really really important in the workforce there in reaching that rural community. CHRs and CHWs are also especially valuable in vulnerable, underserved communities that struggle with multiple barriers to health and healthcare, such as limited English proficiency, unmet social needs, and obstacles to reliable transportation. And again, this was already touched on earlier. I think all these presentations are really doing a great job of just hitting on highlighting really the important aspects of why CHWs and CHRs are so important, but their role in helping to address social determinants of health as well. Okay. Sorry. There we go. Okay. So talking about what are the considerations then for CHWs and CHRs in Arizona. So again, highlighting in 2018, we know the House Bill 2324 was signed into law, and that established the CHW Advisory Council and voluntary certifications of CHWs. And so knowing that this bill was passed, knowing that there was a certification process that was going to be in play, Access did move forward in convening an internal work group, a CHR, CHW work group, really to explore the path for Medicaid reimbursement. And so in those conversations, and just to highlight, these conversations are still happening. Access is still in the process. This work group is still convening to really finalize what we're going to do, how are we going to move forward. And so as we progress into, at the end of our presentation, we'll be looking for feedback, and we certainly appreciate feedback and input that will help guide the decisions that we make as well. So some of the reimbursement models that Access is exploring, the first one being CHWs and CHRs billing as a unique provider type. So actually making a provider type, a CHW provider type where they would be able to bill directly as that provider. The other model would be CHWs and CHRs billing under a medical provider. So a medical provider who is already an Access registered provider, already has a provider type assigned to them as an Access provider type in place. They would work under that provider and be able to bill under that provider. The third model that we're exploring is the utilization of community-based organizations and community health worker organizations. So those agencies becoming Access registered providers, and then the CHWs and CHRs would be employed by these agencies and bill under those agencies. And so then the additional piece that Access is looking at, so in addition to the reimbursement model, we have to consider what is the scope of service that the CHWs and CHRs would be able to bill for. So in our larger work group, we ended up forming a sub work group that really was tasked with looking at the potential scope of service. And so that work group went back and looked at the scope of practice as outlined in by ASCHOW, and also the CHR workforce assessment, and utilizing those tools to identify the potential scope of reimbursement. And again, so the potential services that we have been exploring, and again, these are all just under exploration right now, the patient education and training for patient self-management. And this would be done by a qualified non-physician healthcare professional, so essentially a CHW, CHR, using a standardized curriculum face-to-face with the patient. The other potential services include home care training, both for family and non-family, and then the patient education provided by a non-physician provider, which again would be our CHWs and CHRs. And so again, just highlighting that these services are currently under consideration. They do require additional financial analysis and review. And so this is also where it's important, where we're looking to ADHS and the finalization of the rule to make sure that whatever access proposes or what we are able to move forward with is also in alignment with the ADHS rules and the scope of service in those rules. Okay, so now what does all this mean? What are the next steps? So our path forward essentially is the first step is waiting for the finalization of the ADHS voluntary certification rules. And again, using that to determine the final CHW scope. And then as Alex spoke to the state plan amendment, we would have to draft a state plan amendment and submit it to CMS and get approval for CMS. And in that state plan amendment, we would need to identify and outline describe the education, the training or credentialing that the state will require of CHWs. And then also define which services the CHWs will provide and how they will be reimbursed. We will also need to look at implementing a structure for CHW Medicaid registration and reimbursement. And again, that reimbursement is dependent on the reimbursement model that I spoke about earlier, whichever one of those models we land on. And then we would need to activate billing codes and again, making sure that these are in alignment with the scope established through the voluntary certification. Some of our billing codes are already open. We know that some of the proposed scope of services are current codes that other providers might currently be billing for. And so, looking at the ability for CHWs to bill for those as well. And then if there are any codes that are currently not open, what would be that process be to open those codes? And then this list certainly isn't comprehensive. I'm sure there's a lot of other logistics that we need to look at as well. But once these decisions have been made and we're ready to move forward, the next step would be, and perhaps final step is the training, public information, providing outreach, informing, making sure people are aware that the reimbursement model has been established and this path forward has been established essentially, and then being there to provide technical assistance as needed. So the last thing that we have is, again, like I mentioned, we really value our stakeholders' feedback. And so we have a couple of different poll questions for you. I don't know if any of you guys have ever used Slido, but if you're able to, with your phone, you should be able to access that QR code. And on it, it should pull up some of our questions. And also, if you need to move forward just to open up the poll, feel free to walk up and do what you need so that you can open up that poll. And then, yeah, it should be included in the, okay, there we go.
So
Okay.
we'll give a minute for folks. If you're able to pull that up. Let us know if it's not working from the back of the room potentially.
Yeah.
I don't know if you could hear any of that.
Yeah.
But.
Well, yeah, we'll give everyone a minute or two just
Yeah.
to pull that up. If anyone's having problems, let us know. Yeah, if you need to step forward a little bit.
And then we'll go ahead and start with the first poll.
Okay, so the first question would be, which reimbursement model would be most preferable for access reimbursement of CHW CHRs? So again, these are the three that I mentioned previously as independent providers under a currently enrolled medical provider or under a nonprofit or a CBO nonprofit organization. Or are there other options that we might not be aware of? Okay. I see some movement. It's kind of going back and forth between 1 and 2.
I'll give a few more moments for folks to give their input. I really appreciate it because this is, I think, one of the more fundamental questions that we're wrestling with in the agency is how exactly to structure this, what's going to work best for the community and those of you that are doing this work currently. So really crucial that we get as much feedback as possible to stand up a program that's going to be useful and sustainable.
Absolutely.
While we're still answering the poll, Alex and Leslie, can you only take one of these models back or can you choose multiple models?
No, that's a great question. I think we can stand up multiple models. Yeah, I don't think there's anything that prevents us from standing up multiple models potentially, but don't want to stand up something that's going to be overly burdensome or not useful really in the the current flow of business that CHWs and CHRs currently engage in. So definitely interested in what's going to work best, and if that is a suggestion and a preference that some version of all three of these go in, we'll definitely have time to accept that feedback. I think via our last question, maybe.
And I think
Other, yeah, okay. So maybe that is a good indicator that if you put other, then maybe all three, I don't know, by raise of hands, if that makes sense or what, but
yeah,
makes
and
sense to me.
I think that's maybe the limitation with Slido. We couldn't necessarily make it open-ended or, select multiple. So yeah, so if you choose other, that might be, okay.
We'll go ahead and open our second one.
Okay. So the next one would be what services are most important for access to consider for CHW, CHR reimbursement? So yeah, we'll give everyone a couple of minutes to think about this as well.
So as you all are accessing this poll, Alex and Leslie, other than getting the feedback here, are you going to get feedback elsewhere? Okay, just let us know how we can assist, right? Okay,
Yeah,
great.
absolutely. And so, to be transparent, the work group did begin in 2020. Obviously, that was also right around COVID. And so there were a lot of shifting priorities, but then also with the length of time it's taken for the ADHS rules to be finalized, there's been little pauses at times on the work group. But once we, knowing that the rules seem to be just around the corner to being finalized, I think access is going to be re-engaging at, a more, just at a higher level. And we will certainly be having, community discussions around this. I'm sure it'll be brought to tribal consultation at some point. Yeah.
Okay. Keep providing your feedback. This is a really important time to be doing that.
Yeah,
Thank you
so
for
these
doing
are
that.
great. We're looking at home visit, patient education, health education, social support, SDOH interventions, prevention services, outreach and education, transportation. Yeah.
Alrighty. Looks like we've got a momentary pause in what's coming in. So, again, feel free to, for those on the line or otherwise to put in the chat anything that we might have missed here, but I'm going to go ahead and close this one and open our last poll, and then we'll go ahead and wrap up.
Okay, the last one is specific to the CHR workforce. What services or cultural considerations should Access consider for Medicaid reimbursement?
And Leslie, this probably could be taken to tribal consultation as well, so. okay.
Absolutely.
Thank you.
Yes. Home visits, language barriers. Great, that they might be more clinical, education, transportation, financial circumstances, expanding geographic coverage support, assistance reimbursement with ceremony. These are moving faster than I can read them. Translation, home visits, education. Okay. Great. Yeah, we're seeing some of the same ones popping up. So that's good to see some, identifying what's important to the community. Okay. Great. And, Alex and I will be taking these off outside of the conference. We'll be able to pull this feedback up as well and continue to use it in our work groups. But yeah, we'll give everyone just another minute for this last question. So I've seen cultural practices in there a couple of times, integration, digital connectivity support.
All righty, seeing the participants typing dwindling, I'll go ahead and close this one out and lock the polls. Really do appreciate all of the feedback. This isn't going to work without collaboration. So really do appreciate the initial feedback. And Kim, I appreciate you asking those questions because this is the first of many, places in the community where we'll be bringing this topic as we go to implement and submit the appropriate authorities. So I'll go ahead and turn it over to you.
All right, thank you, everyone.
Okay. Well, thank you to our panelists for all of those wonderful presentations. We're going to transition into the panel discussion, but let me go ahead and take one question that I think came in on Zoom. Can someone go ahead and give us that question? And do we have other microphones for our panelists for the panel here? Just one? Okay. Pass that around. I think we have one question in Zoom, right? Okay. Okay. Yeah, I just wanted to remind everybody that's joining us virtually, please post your questions in chat and we will get to them. But I know we have some questions in the room as well. Just want to note that the microphones are here and here. Please step up and be ready to have your questions answered. Please don't be shy. It's really important that we ask these questions. And I do see a question over here from Jill. Go ahead, Jill.
Hi, good morning. Jill Sapien from the University of Arizona College of Public Health. First of all, I'd like to thank Access and ADHS for being here today and having this dialogue. I just wish it had happened so much sooner. But given that it didn't, and given that today is the anniversary, May 16th, 4 years ago, we passed our legislation. Is it extremely frustrating to see that we're still at this stage? So my big question is to Access people, of course. How long does it take for you to do a state plan amendment? So because you're going to have to do all the work we're talking about first, and then you submit a state plan amendment. How long does it take for that process to come back?
So a little bit, I guess, squishy of an answer. In general, state plan amendments are approved within 90 days of submission. So that's sort of the time frame that we aim for and that our federal partners at CMS aim for as far as approval timeframes go. So once we're lucky in that, well, it has taken longer, but there has been precedent set already as far as approvals go. So there's sort of a few templates out there that we can leverage to sort of get this one across the finish line and hopefully truncate some of the negotiations that might have to take place to speed up that time frame. I think that the state plan amendment approval is going to be crucial. But I think operationalizing and standing up all of the things that we've been talking about is also going to be, a big lift and something that we're really going to have to partner closely around to make sure that we do get those answers in real time and that we can get the wheels of government moving as soon as we can once we're able to hit the ground with the voluntary certification and then the state plan amendment approval, which will ultimately give us authority. But we also do need to stand up those operational structures, system structures in order for the claims to be paid, for folks to submit the claims, or however, whatever that structure ends up looking like ultimately.
Great question, Jill. We do have a question. Want to go to Flor over here first? Flor, go ahead. Ask your question.
Okay, I'm a little bit short here. Hopefully you can hear me. But I just want to say thank you so much for the presentation. I really enjoy hearing what you guys are doing within Access, and also just as putting my advocate hat as a CHW promotora, Floribella Redondo Martinez with ASHA, if I didn't say that. I want to just bring it back to the questions that you asked. What model should we utilize? And I just want to bring it back to the professionalism of the workforce. And one of the things that we've always been thinking about is how do we empower the CHW workforce so they can be independent? We wanted them to be able to be built under an organization, of course, because community grass organizations, we know that a lot of the work happens at community level, the prevention part, the promotion part. Once they go into the medical care, they see the results of the CHWs at community level. So one of the things that I want to make sure that I do say this is that we remember other professions. We see the doctors, we see the nurses, they're independent. They can work with their certification as a provider themselves. So let's look at the CHWs with that hat, with that lens as well, and just trying to advocate for this workforce to be independent and sustainable as well. Thank you.
Thank you, Flor. And I believe we have a question on Zoom.
Yes. Can you hear me, Aaron? Are we good? All right. We have a couple questions online. How can we advocate for more funding or stability for CHR funding nationwide?
So let me go ahead and maybe have Karen from ADHS take a stab at that. I know we have our federal partners also on the call. So Loretta or Michelle, if you want to join in, please do so.
So I think for us is just to continue to, every time that ADHS applies for any type of funding that we're going to be putting out there as RFAs or be putting out to, our partners, which is most of our funding that we do at ADHS, of course, is we put out notices and we generally do like feedback sessions. Those are really important to us just to kind of see where everybody wants the funding to go, of course, within limitations within the grants, but it's really important to really ensure that if you're working within an organization, that you have somebody from that organization attend these feedback sessions to advocate for where the funding needs to go, and absolutely apply and come in with a strong application. More and more we're including CHW, CHR work into our plans moving forward, into even grants that aren't specifically designed or put out there for that workforce. We still find a way to incorporate the workforce. And I'm not the only one at ADHS that has a passion in this. We have many of our senior leadership that's really seen the light and really want to, recognize CHWs, CHR, and promoters more and more. So even if you don't think you're a good candidate, or you don't think that you qualify, put an application out there, engage in those feedback sessions, because we've started to engage more and more with our non-traditional partners, I would say, those that we don't, we've engaged with ASCHOW and, with the advisory council. Those are kind of our standard partners that we engage in and that we, do that regularly. But we have more and more county health departments and community-based organizations that are applying for these grants now. And so we put more of the funding out to the community than we do keep internally. So I think that's a really important thing, is just ensure that you're coming to the feedback sessions and ensure that you apply.
Thank you, Karen. Michelle or Loretta, do you have a response to that question? Do you mind providing us with that question again?
How can we advocate for more funding or stability for CHR funding nationwide?
Okay, this is Michelle. And so that's a great question. So within the IHS I would say, model. We do that each year as a CHR program. We're always asking for congressional increases for the CHR budget. So that's one. You know, a lot of times it just doesn't happen for all kinds of reasons. But I will say that I think we have a good possibility of going from discretionary funding to mandatory funding as an IHS budget, and that would have an impact for, I would say, CHR line item funding. And the reason why that's important is because then that funding is going to be sustainable, and it will then continue to go out in the form of tribal shares. But then that is kind of dependent on population, tribal size, of that type of thing. But I would say beyond that, I mean, those are just these federal constraints that we have, but that's not to say that it can't happen. But I will say data is really important, even data of existing CHR programs that use RPMS, because even as tribes and CHR programs go towards voluntary certification, reimbursement is going to be dependent on a use of a electronic health record. And so we have this mechanism across IHS. You know, let's use it. Let's continue to use it. We are using it. Let's maximize it out. I mean, because that's where I think we're going to get a lot of data that is going to be impactful across the field. So I guess I just want to, reimbursement to me is a way where I think a tribe will step into agency in terms of moving into autonomy, you know, of ensuring billable income comes back to your program through this reimbursement process. And I have had many conversations with South Dakota on this, that is a way, because I've asked them, well, how do we work towards improving and building up the pay scales for CHRs and CHWs? And it's through that reimbursement piece. And of course, I get kind of nervous. Well, is the money going to go back into the CHR programs? And yes, it is. But you have to have some of those pieces aligned through the EHR, through what's happening with the state, what Access is doing, all critical, very critical. So that's my thought.
Thank you, Michelle.
And this is
Go ahead.
Loretta. Can you hear me, Michelle?
We can hear you, Loretta. Go ahead.
Okay, hi. Hello, everybody. So sorry I lost connection. I'm not sure what's going on, but, you know, I'm thinking, you know, with this, when we're talking about CHRs and, you know, how we can advocate for funding, a lot of that falls under the components of patient-centered medical home, right? So we're talking about patient-centeredness, we're talking about coordinated care, we're talking about comprehensive care, we're talking about access to care and quality and safety. So all of those incorporate, you know, as Michelle had mentioned, you know, EHR documentation, that's part of a coordinated care, you know, just working with our interdisciplinary teams, such as a provider, a PA, a nursing assistant, you know, a diabetic educator. All of those components will lead up to patient-centered medical home, and what we're really trying to look at from an IHS care model, and really looking at the whole view, right? So, you know, we have our buckets, and then around that we have community, we have, you know, the cultural competencies and things like that. So just wanted to add that in.
Thank you, Loretta.
Can I
Alex or
also,
Leslie? Go
I
ahead.
also want to add to that, you know, speaking of patient-centered medical homes. So in Arizona, we have our American Indian Medical Home Program, where our IHS 638 tribal facilities can become an American Indian Medical Home. You know, they become accredited with the PCMH accreditation, and then through Access, they get a per member per month rate for our American Indian Health Program members who are essentially impaneled into their facility. But I think that that is another important model in terms of how a funding stream that these American Indian medical homes are receiving can also be incorporated to help enhance the CHR workforce into the tribal communities.
Thank you. So Dr. Saib, I'm going to continue with the questions here, if that's okay. Can we go to a Zoom question?
One of them was a comment, and I'll read the comment first before I go to the next question. As a community health worker, I would like to ask that we be part of the process. It is very important to include us in work groups as well.
Good comment.
And then we had a question from Gilbert. Do level 1 fingerprint cards play any role in voluntary certification?
I think that might be a question for perhaps Karen, right?
Maybe. That's a tough one, and I'm sorry that I don't have a good answer for that. I don't believe so. The conversations that I've had with the administrative rules and council and rules department is we've talked about fingerprinting, but more in the sense that some of the formal trainings out there require that as part of their training programs. But I haven't heard anything that we're going to require that. I haven't seen it written in the rules either. So essentially the rules document, and again, you can visit the administrative rules webpage, ADHS. It's a page off of the ADHS webpage. That's going to have all the rules written there. And you're going to see the qualifications section, 802, section 802. Under there, those probably aren't going to change. Those are where they're going to be. So you would see that under there, but I don't believe that's written anywhere under there.
Alex or Leslie, will that apply to Access, your agency?
Yes,
It will.
Yep.
Okay.
the voluntary certification will sort of be the
Right.
basis, right, for
Okay.
reimbursement.
Thank you. Do we have another Zoom question? Then we'll go to our individuals here in the room.
Yeah, I have one from Miriam online. What can we do to help support the discussion with government officials to aid in the efforts to ensure legislation is passed to support CHWs further? How else can we be involved to help further these discussions?
Did it indicate whether that's state, tribal, or federal legislation?
They did not.
Did not. Okay, does anybody want to take a
Oh,
stab at
she
that?
said state.
State.
Yeah.
Okay. Did we get that question?
Yes, good question. I would say get involved with the work groups are centered around CHW and CHR workforces and pro tortoise workforces. They're really the ones that can help, advocate for and lobby for policy change at a state legislator level. I think that's the best way to get involved is, that's a passionate group of people and you all have one goal. And so you can work together on drafting, letters and approaching state senators or representatives to work towards that.
Great. I just want to say for our tribes and our tribal organizations, we can always work through the advisory council on union health cares for that. But of course, your individual tribes can do that as well. We'll go to a question in the room. Did you have a response?
Well,
Alex?
I just
Sorry.
wanted to say at the agency level as well, we do have a policy development process and we do put all of our policies out for public comment. We post our rates annually for public comment as well. So, and when we submit the state plan amendment, that'll go through an extensive public comment and tribal consultation process as well. So would recommend definitely staying plugged into to those processes and participating when the opportunity is available, because we do take all of that feedback into consideration as we craft our policies.
Oh, thank you, Alex. Can you go ahead and state your name and maybe your
Hi, yes. So I'm Patty Molina with Mariposa Community Health Center, Santa Cruz County, Arizona. So I don't really have a question. I just have more of a statement to make. I'm sure for you all, you know that federally qualified health centers have an all-inclusive rate that precludes Medicaid reimbursement for Medicaid, from Medicaid recipients. So I just think that that's an important part to include when we're talking about the certification for CHWs. Our health department in Santa Cruz County, if you're familiar with it, functions a little bit different than our other health departments in the county. And the department that I oversee actually acts as our county's health department. So it is a community health organization, but we are under the umbrella of a federally qualified health center. So it's kind of a different balance game right there. It's 100% grant funded. And so that's always really tricky. My CHWs have been around for the past 31 years, and it's specifically mostly grant funded, specific to different programs with chronic disease and, health promotion programs. And so it's really difficult as we're talking about the certification process for me to try to leverage whatever that might mean for us, for the department. Then we're asked, we have, that's the whole community. And a little bit later, we'll talk about the clinical and how we are doing some reimbursement for services with our value-based contracts, but I won't give that away right now. But I just do think that that's an important thing to mention.
Thank you for your comment and your feedback. It's really important that we hear that today. Maya, do you want to go ahead with your question?
Yeah, I just have a comment and a question. I'm really happy to hear the questions on Zoom because especially from the CHW who wants to be involved, because I think that suggests that the state is hiring a lot of new CHWs. And so you may not know the history and you should get involved. And I would really encourage you to become members of the Arizona Community Health Worker Association. And they're represented here today. The CHR movement is a wonderful organization to be involved with. And there is a community health worker, a workforce coalition that was the backbone of this work. So I'm saying these things as a preface to my question, because if you looked at the timeline, and I'm kind of re-emphasizing what Jill said, we started this process in 2013. And so it's been, a pretty long road. And I'm looking at the fact that when COVID-19 happened, this workforce, which is pretty much the lowest paid health workforce that there is, made up majority women and majority women of color. I just want to know, when we see other legislation passed, where is the political will? So while I appreciate fully that Access is here at the table, I want to know, and I know that you two as individuals and all of you represented from Access are working, but how do we bring the political will to recognize that this workforce took the brunt force of the pandemic, and we are still talking about a year and a half to do a SPA when we have been at the table, and CHWs with ASCHOW have always been represented at the table and will continue to be, saying this is what we do, this is why we're effective, this is what we need to be covered for. And it feels a little bit like the feedback we're giving you today, we've been giving you for 8 or 10 years. So it's a tough question. I just want to have it in the room to acknowledge the women, the majority women that have been doing this work for 30 years in Arizona. So thank you for taking a tough question.
I think we should start with a round of applause for that. Because you're right, they deserve that. You all deserve that, and then some. But I guess I'll just start by saying, Access is a Medicaid program. We function within very specific federal rules and regulations. Some kind of license or certification or oversight is a general statement is required for reimbursement through the Medicaid program, as in addition to all of the other parameters that exist, right? Medical necessity, the service being attributable to a currently enrolled member, all of the rest that go along with Medicaid reimbursement. Hard for me to speak to the political will question. Since I've been in a similar role in the agency, this has been a discussion, and sort of my entry into that role coincided with the passage of the voluntary cert. So given that certification or licensure is a requirement at the federal level, it only made sense that we had to sort of wait and allow for that process to play out in order to, get the state plan amendment across the finish line. So I think in some respects the political will, was shown through the passage of the voluntary cert. I think that was really the first domino that had to fall in this process. And I don't mean to minimize at all the amount of time that it's taken and the frustration that must have been felt in the community regarding that speed of government kind of factor. But I think hopefully that helps to provide a little bit of additional context at the very least. I'll stop there and see if ADHS, Kim, I'm not sure if anybody else has anything to add, or Leslie, if you have anything to add.
Anything else to add, panelists? And anybody on the Zoom have anything to add regarding that question? Thank you, Maya, for your question. Any other questions on Zoom?
Yeah. Anna has two questions. I'll just read the first one because they're both pretty big questions. Knowing that the ADHS voluntary cert rules are in the process of getting finalized, can Access submit a SPA to CMS prior to the final approved admin rules?
Alex or Leslie?
I suppose we could. I think the effective date would largely be contingent upon those rules going into effect, though. So we could, and we're planning to submit a SPA with the effective date of the rules going into effect as is. That's the current, path that we're headed down. We do have some flexibility left, to prepare for that. But it's definitely something that we can discuss, whether here or offline, to figure out what that looks like. It's just that when we submit it, we would hate for us to submit something and then the final rules come out with sort of a nuanced sort of change, and we already received the approval, then we would have to go back through that process again. So really, we wanted to know sort of what the playing field was and what we were working with, in order to make sure that our SPA was, based on the voluntary certification. But definitely a conversation that could be had.
Okay, thank you, Alex. The second question.
Yeah, she had a second part. Should Access consider CHW reimbursement / billing under a CHW organization that what potential requirements should those CHW organizations anticipate? I'm sorry, let me read that again for you. Sorry. Should Access consider CHW reimbursement / billing under a CHW organization? What potential requirements should those CHW organizations anticipate? I understand that those organizations will need to apply as an Access provider. How long will the process take before they can bill for CHW services?
Yeah, that's a great question. Excuse me. So those organizations would, I'm not sure who answered that or asked that question, but as they asked, indicated that those organizations would just have to go through that process to become an Access registered provider. I don't think that it's a timely process. I think that Access has, specific metrics that they try to meet in terms of getting providers registered and whatnot. And then those agencies then would need to follow that certification requirements that are outlined in the ADHS voluntary cert rules.
Yeah, and I think that most of the work, a lot of the work anyways, is going to be setting up our internal systems and establishing that provider type and setting up the policy and the parameters. But Leslie hit the nail on the head. I think that, as far as expectations go, that would be the structure that we're kind of contemplating under that option would be that, yeah, the CHW organization would be the enrolling provider. And then that organization in this situation would be responsible for, making sure that the CHWs have the appropriate certification, they meet all the applicable requirements. They would be the employer, if you will, and then the CHW could then bill under that organization. The organization would really be the responsible party for enrolling, and then, monitoring those activities, et cetera.
Sorry, I think the last part of that question was how soon they'd be able to start billing. I mean, they would be able to start billing immediately. I mean, as soon as that provider registration is in place.
Any other questions on Zoom?
Yeah, we have actually one more. Will years of service be taken into consideration in lieu of certification?
So this was actually the point that I was just going to touch on for the other question too. I think it's really important as an organization or individual CHW, CHRs, promotoras to really read through the rules and those qualifications and reach out to ASCHOW or myself, Karen Watts at ADHS. My email is pretty provided everywhere, but reach out to us to get clarification if you have any questions surrounding those qualifications, because remember, they're kind of written in a very legislative way. And there's some confusion in the qualification, especially when it comes to training, whether in experience or voluntary or paid experience and what you need for that qualification. There's 4 options under there. So one of the options, and this was the original one written in the original statute of 23024, was that you could have experience only and not formal training. And then the next options go down to give you an option of having experience and training. Because we did want to acknowledge that there's a lot of CHW, CHRs, promotores out there who have been working for a long period of time now, building up their experience, and maybe haven't gone through a formal training because their training was the experience. But however, I want to highlight in that's option A in there. And again, if there's questions of, making sure that all of the CHW, CHRs, promotores that you employ qualify, reach out so we can go over that now, so you can start preparing for once these next steps come up. We can have, because can the rules be changed at this point? Yes. We still have comments that are being reviewed right now. There's going to be comments during the oral proceeding that need to be reviewed. Maybe substantial changes won't be made, but then will the governor make changes? Will he decide he wants to change it? We can suspect not, but we don't know. And then the review council, will they want to change it? So yes, changes can be made, but I'm pretty confident that training piece, because it had been changed and worked through pretty extensively, that's solid. So but what going back, really important to highlight is that you're looking at the 960 hours of paid or volunteered experience. It has to be within the last 3 years. So, and I know that's really unfortunate, but unfortunately, just based off the statute, that's what was written in the statute. And unfortunately, well, really whatever's written in the statute is law. That's going to make it into the rules automatically. And then there were a lot of changes made. So I think it's really important to start looking at how you're documenting your hours. If you haven't been documenting your hours, work with your employer to do that now, because in order to qualify for certification, you're going to have that. So yes, there's an option to have experience in lieu of like formal training or any type of training, whether that be at an academic institute or within a community-based organization training, or with the IHS national CHR training as well too.
Thank you, Karen. I know we are at time. Dr. Sabo, did you have a question? We'll end with Dr. Sabo's question.
I had 2 things. One was I wanted to assure everyone that we'll make sure that you have the emails and the contacts for all of the initiatives and opportunities for involvement, so you can make sure that you stay connected. I think my question to Kim was really related to kind of what are the opportunities for starting, piloting things? Is there opportunities within, before you get approval through the SPA, of kind of demonstration projects or things like 1115 waivers or other types of levers that could maybe get some things going and kind of pilot them, figure them out, shake them out a little bit before the full SPA? Or?
So yes. Yes, is the short answer. I'll just caveat that by saying we operate the majority of our program at Access under an 1115 waiver. We're actually actively negotiating our renewal right now. The smallest 1115 waivers take upwards of 6 months from conceptualization through public comment, submission, negotiation, and approval. Usually that time frame's more towards 10 months or a year. So while that is an option, where we're at currently, we see the light at the end of the tunnel with the finalization of the voluntary certification. The state plan amendment approval process is much shorter than that, which is good. The last point I want to make there is, once a state plan amendment is approved, it's a permanent change to the Medicaid program. We don't have to renegotiate it. That funding source, that sustainability factor is there until forever, until we decide to change it. But that's not really on the table here being contemplated, right? So it's a much more solid approval, I would say. With the 1115 waivers, you have to go back and renegotiate every 5 years or ask for reapproval every 5 years. So it does really benefit, I think, the system in large part to have this codified through a state plan amendment as opposed to any kind of waiver, because when it does get approved, it's a permanent fixture in the program, and it's statewide, right? it's not limited to a certain population as long as they meet the medical necessity criteria for the service being provided. Every member is able, that's enrolled in access is able to access services provided by a CHW or CHR. So long answer to a short question, I think, but yeah.
Well, thank you, everybody, in participating in this moderated panel discussion. You all had some really, really good questions. You all are really great at advocating for your clients, and you're also really good at advocating for yourselves, as demonstrated by your questions today. Can you all join me with a round of applause for our panelists? Thank you for all our partners at the ADHS Access and IHS for taking our questions. A lot of really good questions. And I think we can depart for lunch, right, Dr. Sabo?
Yep, we welcome you. Thank you, everyone. We welcome you to have lunch out in the south area, north area. And for those of you online, go ahead and take a break, go breathe some fresh air, get away from your screen and eat some lunch, and we'll join back again at 1. So we have about 45 minutes. So thank you.
Thank you, everybody.
But we'll go ahead and get started into our afternoon session. And I'd love to invite our moderator, Maya Ingram, up, and all of our presenters that will be doing our next session, which is really what is going on the ground. So we had a wonderful session in the morning from our state and federal partners to see these big picture levers. And now we'll be moving towards the work. So what are federally qualified community health centers? What are tribal health CHR programs and other health plans doing to better integrate CHWs and support this workforce? And so we welcome them up. And I'll get you another chair. And for those online, we'll start right about now, and we'll do the same format where we'll have each presenter present. And then we will open up the chat for questions and dialogue, which will be moderated by Maya. So welcome, Maya, who will be introducing the speakers.
Well, hello, everyone. I'm super pleased to be here today as the moderator of this session, because this is where you get down into how it really happens. This is down to CHW and CHR and promotora work and all the creativity and innovation that goes in to finding a way to fund these programs without reimbursement, which was the beginning of our discussion, but still to recognize the incredible work that's being done in the field and how organizations and CHWs are making it work. So I'm just really excited to be listening and hearing these presentations. And I know that we're going to get a lot out of it, and there's going to be a lot of questions because many of you are starting programs, or you're trying to grow your programs, or you're trying to figure out how to do things differently. And there's going to be some wonderful ideas from the panelists. And we'll run this pretty much the way we ran the last one. You have the bios of everybody in your program. So I'll just kind of run down who's going to be presenting and in their order. And then they'll just come in and present so that we don't have to, they're very, you'll learn a lot about them in the bios, but they do take a little bit of time to read. So first we have a presentation from Mariposa Community Health Center with Patty Molina, the Senior Director of Community Health Services, and her colleague Miriam Morales, the Manager of the Care Coordination Department. And then following her, then we'll move on to Nora Lozano, who is the Community Health Worker Manager for Quality Health. Then third, we will have Jody Tate, and she just started in Canyonlands in 2021. And she'll be speaking about her new program in the Canyonlands Health Center. And then finally, we'll close it out, not last but not least, with JT Nacio with the White Mountain Apache Community Health Representative Program. And she is the CHR Program Director there. And then after that, we'll again open it up like we did last time for questions and discussions, and I think have a really wonderful time. So I'm going to turn it over to my really good friends at Mariposa Community Health Center, and we'll get started.
This is so funny because they said that we'd be able to see the screen right here. You can't see anything because the podium is just like right there. All right, so I'm Patty Molina, Senior Director of Community Health Services with Mariposa Community Health Center. Our community is in Nogales, Arizona. Santa Cruz County is the smallest county in the state of Arizona. These are just a little bit of statistics. I'm not going to go through the entire thing just because you see how many panelists we have, and this could take a while. But I did want to show you these maps right here so you can see the map right at the bottom right there. That's where we're at, really close to. Is it not advanced? Oh, that's just because, I'm sorry. You guys are controlling it. I'm controlling it here. Where is it? Here. There you go. Okay, so you see right there, the bottom right there, that's Santa Cruz County, right at the border to our sister city in Nogales, Sonora, Mexico. And then you can see a picture there of the border wall that goes all the way across right there. So those of you that work along the border, you know exactly what I'm talking about. Did it go? Yes, okay. All right, so about our health center, established in 1980. It's a federally qualified health center. We have 5 clinical sites. I don't need to tell you all about what FQHCs do, but we have complete primary care, including pediatrics, obstetrics, gynecology, family medicine, dentistry, behavioral health, full service pharmacy, lab, et cetera, et cetera, et cetera. So I'll talk a little bit more about community health services now, which is the department that I oversee. The way it's known in the community is called Platicamos Salud, which roughly translates into We Talk Health. It began as part of one grant to develop our CHW workforce back in 1991 through the Office of Rural Health Policy. Our CHWs pretty much make up about 25% of the overall health center workforce now. They have many different names. We started them out as promotoras de salud. Now they're MCH case managers, case monitors. We even have teen health facilitators that are actual high school students in high school that do peer-to-peer outreach on risky behaviors with other teens. An array of different names. The picture right here is we just celebrated our 30th anniversary last year, so it's pretty neat. So Mariposa CHWs are everywhere. We do community outreach, screening, referrals. We do group and one-on-one education. We do case management. We do surveys out in the community. Assess social determinants of health, which are really important in terms of addressing health promotion, disease prevention, and everything that we do out in the community. They are change agents. They do a lot of advocacy. We don't have any public transportation in Santa Cruz County, so a lot of our patients have a really hard time getting to appointments. We do offer transportation as part of our health center, but of course, that's always hard. Sometimes you can't always get an appointment, and sometimes it's last-minute appointments where you need to get to the doctor. So our CHWs advocated with these independent bus companies to be able to get one of them at least to take them directly to where they need to go to, either our clinic site or the hospital. We only have one critical access hospital in Santa Cruz County. So that was really neat that they put their efforts together to do this. The training for some of our CHWs, for us specifically, it's really dependent on what the funding source is. Like I said, there's 2 different forms that we work with within Mariposa Community Health Center. We have community versus clinical, and so that is something that's really important. For our community-based community health workers, the funding source really is what feeds on what the training is going to consist of. And so whether they're working on diabetes management, whether they're working on heart health, whether they're working on asthma education, et cetera. CHWs has a lot of capacity that's being built through the ASCHO, the Arizona Community Health Worker Workforce Network. It's really important to us. And so we continue to support what they have to offer and trainings that they have to offer. And I advocate for them and ask you to utilize them as a training facility, training source for your CHWs as well, because they do a really great job. Some examples of the trainings that we've had based on the funding needs for us is like hearing loss, diabetes, cardiovascular disease, leadership advocacy, oral health, and there's many more. I don't need to keep reading all these right here. This picture right here is really significant of our CHWs. This is the one I was telling you the story about, advocating for a little bus route that gets to our hospital. And these are the 3 promotoras that worked on that particular project right there. So it's kind of neat. And they made a paper sign, but it was out there and people were utilizing that to get to the hospital. So Maya's laughing because this is one of the projects that was part of the PRC. So yeah, it's really important. The promotoras de salud or community health workers really are, they reflect, the cultural and linguistic needs of the community. I don't need to tell you this and how that's important in no matter what area or population you're serving. But for us, they're predominantly Spanish speaking because our population is primarily Hispanic, 85% pretty much, and Spanish speaking. They understand those cultural norms, the values, the beliefs. They come from those neighborhoods, they come from those communities, and that's why we seek these types of qualifications for the CHWs that we gain to do the work. They're familiar with healthcare, not just in the United States, but in Mexico too, so they can understand those things. And then they have all the understanding of issues, especially as they relate to the migratory status. But really, they are trusted members of the community, and that's what's important. And that's what really makes the services that they provide dynamic. So this is another important one here is why CHWs, because they act as a bridge to healthcare and social services. They are able to provide one-on-one education with the patient. They are able to do group education in a manner that is culturally sensitive and empathetic. They are able to go in there. All of the CHWs within the department that I oversee have access to our electronic medical record. And so they can go in there and report back to the provider team that this person, because the provider referred the patient to diabetes management, that they attended that class and what happened within that class and any questions that they might have. One of the number one things that we tell our CHWs is do not answer any medical questions. Always put those in the little note sections of the EMR so they can go back and relay those questions that the patient might have had based on the education. Regardless, they really enhance that team-based care. And I'm not really going to go much more into detail with that right there because I'm going to let my colleague Miriam really talk about that in a little bit right here. All right, so I'm going to talk about that clinical integration. When we first began this clinical integration within Mariposa, this was back in 2012. So these are the lessons learned from what happened back then. And then Miriam's going to talk about where we are right now. Basically, our medical providers really have to be trained on the skills and qualifications of our community health workers. So they have a better understanding of what the benefits are, not just to the patient, but to the overall health system within what we're working with. Training and clinical care team meeting, the format, it didn't support CHWs. And that really put us back in terms of being effective with communicating with our community, with our providers. We learned that you just can't add a CHW to a care team. That needs to be a change in the system so that it recognizes those, again, those values that supports the CHWs and what they're capable of doing. The need for more efficient and targeted system which led to the elimination of weekly clinical team meetings. That just wasn't working either. Those clinical team meetings were just becoming a mess and it just was not working. CHWs were trained in the electronic medical records, allowing them to identify patients who needed their services and easily communicate with the clinical staff. That was a plus. Now we have a more clearly defined scope and targeted population so that we can focus on those patients that have the highest risk need for care transition. So with this, I'm going to transfer it now to my colleague Miriam so she can talk about Mariposa Care Plus.
Hi, everybody. So, well, I'm just gonna go very quick and tell you how the CHWs came into our program. So at Mariposa Care Plus, we're a provider lead care team program that collaborates between Mariposa's physicians, nurse practitioners, and who are trained for the diagnosis and management of complex chronic medical conditions such as diabetes, hypertension, asthma, etc. So we work together with a lot of the different departments within Mariposa, So I know I'm not gonna go into detail as much, but I just wanted to tell you guys that we are part of value-based programs. So that's the way we get reimbursed by the insurances. So we have access to the major hospitals portals where we get the information. So with that, that's how it triggers to my next slide, where that's how we assign patients and assign them risk levels according to the severity of their chronic conditions and their ER utilization and readmissions. So before, like she said, when all this started, I did the levels because I didn't have manpower to do this. So it was just 2 of us. So that's why I just said, okay, what population can we target? So I just target the more complex ones. From there, we expanded, and now we do have a nutritionist, and we grew up to 8 people, including myself. So I'll go really quick of how some of the services we provide to our patients. So the nutritionist provides nutritional counseling, education, and meal planning. We work, like I said, with specialists and other healthcare providers. Like even when they're discharged from the hospital, we make sure that they can come back to their PCP, or if they need transportation, we take them to Tucson, Sierra Vista, wherever they have to go. I mean, we provide that service because that's a barrier we have in Nogales. Another one that we make sure that we empower the patients to make their own healthcare decisions. So we also, teach them how to navigate the healthcare and the behavioral health and services. And actually, we also discuss advanced care planning. We identify available services within the community. So we do have home visitation services that we do assessments, and we also assess the social determinants of health. So my next one. We assist on medication reconciliation, but that one, I made a new slide for that because it's very important, that services that we provide. Like I said, transportation and the integration of behavioral health, and we do referrals like for, DMEs, which is durable medical equipment, hospice, or any specialty that the patients need. I wanted to spend a little time on my transitional care because this is very important. This is how we get the reimbursement. So we get the discharge note from the hospital, and we make sure that we include our internal clinical pharmacists because they're the ones who can do medication reconciliation, medication management. So we do mutual visits. So that's how we identify any barrier that the patients might have. Like, let's say we noticed a patient with a hemoglobin A1C of over 10, 13, or 12, something like that. We did a home visit, and it turned out that this patient did not know how to administer their EpiPen. They were just dialing it, but they were not pushing the insulin. So all that is very important for us to point out that our clinical pharmacists help us identify all this and help the patient as well. So the target population are the ERs and the high ER utilization, which I mentioned before, is like the complex patients because they have 2 or more comorbidities and a lot of medication that we need to make sure that they understand how to manage that. And the inpatients as well. So if we are notify when a patient is admitted, so we keep an eye on them. So because whenever they get discharged, we want to make sure that they go back to their PCP. Thank you. And how can we achieve this? Like I said, because we have a very robust teamwork inside our Mariposa. We work with Patty, we work with outside agencies and all that. We do like I said, the medication management, the assessment that we do at home and all that. So I believe that by doing all this teamwork, we can achieve the reducing the readmissions and all that. So we have this one that I wanted to share that if you see this graph, our expenses increase over the years because we were able to reduce those ERs that I'm telling you, and those readmissions. Like if a patient went to the ER for UTI, we got him back to see their PCP. So because of all that, we were able to keep patients out of the hospital and able to generate this. And we have some certifications as well. Like HRSA gave us a certification of achievement in 2018. And I know I have 1 more minute, and there we go. Do you guys have any questions? All the questions at the end. Okay, so now I'm gonna pass it to Nora. And there we go. Okay, so thank you, everyone. My name is Nora Lozano, and I'm the Community Health Worker Manager with Equality Health. I want to tell you guys today a little bit about community health, and it is not a new concept. You all know that before primary care providers existed, it was a common practice for individuals to reach out to their elders, to their healers, and to the people that they trusted in the community for advice, information, and remedies, right? It is still a common practice in some communities, including my culture, the Hispanic culture, that we go out and ask for information for the grandma, the mom, the tia, the comadre, right? The neighbor in your community that you trust, and you go out and outreach for that information that you're looking for. Promotoras, or community health workers, like we call them in English, are that trusted member in your community that you can go and reach out for information. Actually, now we reach out to you, right? But it is still that trusted member in the community. Promoters and community health workers didn't start emerging until the 1960s in Latin America. And around the 1970s, they started blooming, right? And so this model of care was funded through the popular education through Pablo Freire. This popular education really was funded in the praxis and social change. And this happened because social change and practice in popular education involves culture, involves art, involves food, involves educating that person, providing that concept, and the person makes it their own. And then they see the benefits of why this is important and how the impact is gonna do in my life, in my family, in my community. And then I'm gonna adapt that concept, and then the social change starts happening. That is how community health workers, promotoras, and CHRs are doing the work that they are doing in your communities, because we are involving the communities that we belong to, and we are making that social change, those social behaviors that we are changing and making them understand the importance for their own benefit, right? So let's see if I can change. Oh, there we go. So community health workers, they are helping your communities and my communities to end those health disparities that, that are out there. Health disparities are not a new concept either. In the United States and the whole world, certain races, ethnicities, and communities are more disproportionate affected by these health disparities. And before I go on and how community health workers, promotoras, and CHRs assist to help end the health disparities, I want to tell you how and why Equality Health was created. Equality Health was created to end health disparities, to improve the health outcomes of individuals, families, and communities, to reduce the cost of care, and also to improve the way that individuals access to healthcare. So that's what our promotoras and community health workers are doing out there. And talking about, it's the other way. Okay, so talking about how we do it, we partner with a network of providers, and we assist their patients to access to health care and to overcome the barriers that they have. But we also contract and partner with the health plans so we can coordinate that our members are receiving the benefits and the services that they have available through their plans, right? So how do we do that? We believe in the whole person approach. We know that health means a different thing from culture to culture, right? So we know that, like my dad, I told myself I was not going to say this, but my dad, for the chubbier I was when I was little, the happier he was because he thought that I was healthier, right? So health is different from culture to culture, but we know this approach, and so we are patient-centered. We believe that it's body, mind, spirit, and environment, because you cannot have one without the other. So how do we do this whole person approach? So we do it through an interdisciplinary care team. Our nurses and nurse practitioners take care of the clinical needs. Our social workers take care of our mental health and substance use disorders. Our chaplains assist that spiritual support, and if that's what the member wants and believes, regardless of the spiritual beliefs that they may have, they are there to pray with them and for them if that is something that they are accepting from our chaplains. And we have the community health workers and the care specialists that specialize in focusing on those social determinants of health to eradicate those health disparities. So the social determinants of health, as you all know, are those factors that are affecting our lives. Yes, access to healthcare is important, but it only accounts for 20% of the health outcomes of an individual. The rest, it's directly tied to your zip code. It's directly tied to the social determinants of health. And we can see here, and I believe that somebody else already presented this little guy, but it is that the behaviors that we have, the health behaviors that we have are going to affect us. Because if I'm a drinker, a smoker, if I don't have my 8 hours of sleep, or if I don't drink that water, or if I prefer not to exercise and eat lots of sugar, that is a behavior that is going to affect my life and my health. We also have the environment. What about if I live right next to a factory and I'm breathing in all the fumes, right? That environment affects me. Or what about if I live right next to an avenue that is really busy and I try to be healthy and I go and take a run and I get hit by a car? That's the environment that is going to be affecting me. But also the social economic factors, right? The schools that we go to are determining the education, the quality education that we have access to, and that is directly tied to the jobs that I'm going to be able to get when I get older. And that is going to be directly related to the money that I'm going to be able to make. And that money is going to be directly impacting what house can I afford and the food that I can buy, right? So the community health workers are there to support all those social determinants of health, because maybe I won't be able to give you the money for your pay rent, but I'm going to be able to be that bridge to that correct resource in the community that is going to support that need for you, so you can save that little money to buy maybe better quality of food, or maybe to afford that co-payment for your medication. So that is the impact that the community health workers have. And you may be thinking, okay, so you may be thinking, how do I get a community health worker in my program, in my organization, right? Thank you. So you had a lot of time to think. So now you know you want a community health worker in your organization and you want a community health worker in your programs. How do I do that, right? Why? I already told you we are trusted members in the community. All our community health workers belong to the communities that they are serving. So and we're coming soon to Flagstaff, so be ready. But all our community health workers belong to those communities. They know and understand not only the challenges of that community, but also the strengths of the communities. And they understand because their kids go to the same schools and they shop at the same grocery store. And so they have that ability to build that special relationship with the community members that they are serving. And when we are community health workers, you've probably, and CHRs and promotoras, you probably know and have heard that you wear a lot of hats, different hats. One day you are an advocate, one day you are an outreach worker or a translator, an interpreter. Today you went to get a food box. Sometimes I feel like I'm a real estate person because I try to find housing and I'm like, this is impossible. We are in Arizona. Haven't you heard? We have a crisis, but we are still looking for houses and affordable on top of that, right? So, with those hats that we are putting on, we have to have skills. And those skills come with the core competencies that the state of Arizona is supporting and validating the health workforce that we are using. So all these hats need specific skills, and those skills are going to come through the certification. That certification that we are talking about, that we want to pass and we want to have, is going to make sure that when you employ a CHW, you are going to know that you are going to get that person that is going to make your program successful, because it has all these qualifications that you want and you have heard that they are successful. So we also, like Mariposa and other, we do contract with value-based. But you were wondering, while I was struggling over here, you were thinking, how do you want to incorporate CHWs in your program? So a lot of programs, we already heard that they are grant funded. And yes, it's hard and it's not sustainable because you never know if you're going to get that grant or not. But when you have that reimbursement, or when you have value-based contracts, then you can be more sustainable per se. However, I want to let you know that sometimes even the community health workers, we work from the heart. CHRs and promotoras also do that. And some of them are volunteers. But here's the thing, that we need to recognize that the profession and value that profession, and we need to start supporting that these community health workers, CHRs and promotoras, are full-time employees. And that's what we want to support through this movement, right? So in equality health, some of the common goals that we have for our community health workers is to reduce the rehospitalization. Yes, we outreach out to our members when they're coming out of the hospitals, and we want to make sure that they go see their PCP within 7 days, and we do the transition of care support, just like our friends in Mariposa are doing, right? We also want to decrease the cost of care. We want to address social determinants of health. We want to increase the engagement. We not only want them to go see their doctor when they got out of the hospital and forget about that. We want them to be engaged, and we want to have a relationship, and we want to continue to have that continuum of care with them. So those are some of the goals that our community health workers have. But really, one of the biggest predictors of the success is those relationships that we are building with the members that we serve, because they know that we care, and we know that we care. So they, when they find themselves in a pickle, normally they call us back, and that's what we want, because they are not going back to the hospital. They are reaching out to see if they can avoid that, right? Because they know that they can trust in somebody else. Sometimes they don't have any other option but just go back to the hospital, because it's all they know. So how do we do that? Our community health workers, we equip them with technology. They have tablets that they go to the home visits, to the hospital visits. They have technology that they access, right? We have data, and we have some very smart people in the data department, that it's not me, that are analyzing that and letting us know who do we need to outreach in order to reach all those goals that we're talking about. We outreach our members, then we engage them, and then we have them engage their primary care providers and their specialists. And not only that, then we are having them engage with community-based organizations. And through that, we once we are in their homes or engaging with them, we not only go to their homes, we, as I said, sometimes we go to shelters or to the McDonald's in their community if they are on shelter, if they don't have a home or they don't feel comfortable having us in their home. But our main goal is to address the social determinants of health. And somebody else was saying before me that if you want to have a community health worker program, it is very important to have a specific roles and responsibilities and know exactly the scope of work that your community health workers are going to be doing out there, because there's limitations and there are boundaries and there's scope of works. And that's why we have interdisciplinary care teams, because we are not mini nurses, we are not clinical. So we are not there to do medical advice or administer medication. We are not. We are there to be that bridge. And if we find and identify or you self-disclose that you have this need, that we are not it, because I always tell my team, we're not it, but we're the bridge to it. So we then should be connecting them with the appropriate, I have 1 minute, with the appropriate resource in the community. So as I was saying, we do connect them with community-based organizations. We have our own community health organization network. It's called Link AC. And that way we can do a closed loop referral for our network. And well, this I think that we can address in the panel, because these are the advantages of that community health worker volunteer certification. So she told me my time is up, so thank you very much.
I'm so excited to be here. Thank you, Sam. I recently went to Las Vegas, went and saw a comedian. He was talking about middle child. Do we have any middle children in here? Raise your hands. Middle child. So the fact that I have a platform where I can speak for 15 to 20 minutes and not have someone interrupting me, like that's a dream. So thank you, Sam. My name is Jody Tate. I work at Canyonlands Healthcare. We have, there's a little bit about us. We have 9 clinics. We are in 7 different counties. So we're kind of all over. We're 6 counties here in Arizona, and we have 1 county in Nevada. So we're really spread out, and we are entirely in rural communities. Was it the big button he said? Big button, big button. All right. So first, I'm a connector. I want to connect with people. So I'm just going to tell you just a little bit about me. I'm a firm believer that when you know somebody, it's really hard to dislike them, right? Like, I mean, you might dislike me a little bit, but I feel like as soon as you make that connection, it makes it a lot easier to be like, you know what? Jody was really nice. I want to help her. And likewise, you watch them, you're like, oh, I'm going to help them. So just a little bit about me. I grew up in Las Vegas. I come from a pretty large family. I have 4 sisters. So you can imagine my poor father, you know, how that, I think that's all I need to say for that. I currently live in Page, Arizona, which is about 2 hours north of here, home to Lake Powell and Horseshoe Bend. And as you see behind me, arguably the most beautiful slot canyon in the world, Antelope Canyon. So if you have not been, come visit us. We also have an annual regatta that's really fun to go to. And that's the first weekend of November. I've been married for going on 17 years to my husband, Aaron, and we have 2 kids. This is Zoe and Cole. Zoe was Belle in the musical this year, and so that was really fun, except for she had to do her first kiss in front of her mom, and that was really awkward for both of us, but it was fine. And we love sports. Actually, who was it? Oh, Kim Chinley beat us on what day was it? Saturday, but that's okay. We came runner up, and Chinley was great. So that's just a little bit about me. So my presentation might be a little bit different than everyone else's, and hopefully that's not a bad thing. If it is, then it's okay. Just don't call me. Just you never call me, and I'll come and watch everyone else's great presentations. But I really want to talk about why we are here, right? I mean, how many people in here works as a community health worker, CHR, or promotora, or runs a program? And then how many do we have on the clinical side in here? All right, so a little bit of mix of both. Okay. So I think it's really important when you know why you do something, then that starts to inform how and what we do, right? Because when we do that the other way around, sometimes we miss the vision and we miss the pieces that bring that together. So for my why, this is my sister, Megan. She was born deaf 40 years ago, back in the 80s. My parents were poor, living at my grandma's house, didn't have the ability to make ends meet, right? And I think of the difference that would be in my sister's life had she had somebody that could have guided, that my mom could have had to connect her and be that bridge to those resources. That was very difficult. And it's very difficult to grow up with a disability. And, you know, she's thriving now. She just got married this past October. This is her husband, Kevin. And she's really happy, but having someone to help her navigate that would have changed her life. And it would have changed my family's life. It's personal to me. That means something to me. And this is my mom and my dad. This is my dad, George. He died 5 years ago at the age of 57 from complications of his unmanaged diabetes. And I think, you know, I run the diabetes program for our, I oversee that with our community health workers. And I think of what a difference the classes and the physical therapy and all the things that we do and the interventions that we have, what a difference my dad's, even if he would have passed at the same time, the quality of life that he would have had, right? So this is my why. You know, losing my dad at such a young age propels me to continue to fight for ways to come together as a team. You know, I see this as a team approach. I think sometimes it's easy to get into our silos and our boxes, like I do population health and I do clinical and I do financial, when really we're a team, right? You know, going back to baseball, you can't win if you don't have a good first baseman, right? I mean, we're all in this together. And if there's infighting, then we are not serving anybody. So I was going to talk a little bit about our beginning. The slides, I'm sure, are being sent out. You guys can read these. I will just highlight right here, as you saw from that first presentation, what Patty has going on at Mariposa, I feel like is the training measuring stick that I know for myself that I look up to, because they're doing so many great things and they are incorporating so many great programs. Her team program, when I went down there and she told me about it, I was like, oh my gosh, we have to do that. We're trying. But so that's just, you know, we have, let me get through these. These are our community health workers that are up with me and Paige. They serve Chilchimbato and Kaibato. This was just this last week. And in Kaibato, there was a mobile health unit out there for mammograms and mobile women checks. So we'll go through that just a little bit. Like I said, you guys are going to get these slides and you'll be able to kind of look at these. These are some, we have written our CHWs into grants. So we get down back to the team effort, right? Because I think sometimes we look at the clinical side and sometimes there's a battle there, right? Like we all know it is. We all have that doctor that's a little bit arrogant and maybe isn't going to refer people, or maybe it's a little bit difficult. And that happens. And that's not a poor reflection on anybody, because, you know, I'm able to offer a unique perspective. My husband, Aaron, is an emergency room provider. And I think that has helped me to take a step back and to, you know, when I hear sometimes some people like, oh, complaining, and I know that when providers go to work, they care about their patients just as much as when I go to work, I care about my patients. And I was finding that we were saying the same thing, but we were sharing a different language, right? Like we had the same desires. We all wanted to help, but the way that we were trying to accomplish that, we were trying to do it in our silos and we weren't coming together for that. And that was creating not barriers just for us, but we're trying to help our patients overcome barriers. And I felt like we were putting one more barrier in front of them, which was sometimes my pride and maybe sometimes the provider's pride, right? So I like to solve problems. I like people. I'm like, I love, like, let's figure this out. How can we all be friends, right? You know, I'm not short of bribing. Patty will tell you when I came up, I brought food. Food speaks volumes. How many cultures can sit down at a table and break bread if you don't eat the same, or not eat, speak the same language? Food brings people together. So I will do, you know, nothing short of bribery to get this together. And I thought, what do these providers want? They want to know how we're helping their patients, because that's what's important to the provider, right? They want to say, okay, if I'm going to relinquish a little bit of control, because that's a little bit nerve wracking for a provider to say, all right, go meet with this person. I don't know exactly what they do, but go for it. Right. So I wanted to make sure that it was a team effort and that they had a voice at the table and that we were listening to that voice and informing the way that we did our program based on some of their feedback, and then also ask them to listen to ours, because once you listen to somebody, they're much more willing to listen to you. So these are kind of the things that we have done to cultivate trust with our clinical team. We share data, and I know sometimes data is like that ugly word, but that is what informs what we do. You know, like I can't tell you how many times I've told our providers, just put the referral in. I know you don't have to have the referral, but that's the only way I can track who is not having those referrals done, so that I can say, oh, hey, we're not reaching this population. We need to refigure out why. And so, you know, helping to explain my why to them. This is why I want you to do the referral. I know you know how to do it. You know what I want you to do, but back to that why. Why am I asking you to do this? Communication. So, I'll show you some of the data that we share. So we use a population health tool called Azara. And I think Mariposa has Azara. A lot of people in the Alliance has, if anyone's part of the community health, the Arizona Alliance of Community Health Centers, they use Azara. So I created a dashboard. So anyone that is in my programs, the clinical team can get in and look at the dashboard, and they can see, as you can see right here, I have it spread out into our patients that are in our programs with our CHWs, and then patients that are not in the program, they're just our overall patient population. And I'm helping this is what providers want, right? They want statistics. And I'm able to go to our doctors and say, hey, look what's happening with your patient. As you can see here, we've had a huge improvement in our patients, and this program did not start until January. All right, so this is just from in the last 5 months. This is the type of progress that we're seeing with our patients. And it is attributed largely to the community health workers, a lot to our clinical pharmacy team, but also a lot to our providers, because they are listening and they are referring patients to our programs, because we have created a relationship where it's trust, right? We always talk about, you have to, if a client, if a patient is going to work with a CHW, they have to trust them, right? So if we want providers to work with us, they have to trust us. And how are they going to trust us? You tell them, I'm doing a really good job with your patient and they love me. And so, and we'll talk about that in a little bit, how we share the love part, because we do some surveys with our patients as well. So we share this data. So we had a 20% improvement and an average of 1.2 A1C, a drop in A1C. And that's including patients that still haven't had it retested. Most of the patients dropped almost 2 A1C points. That's huge, right? Like going back to my why, if my dad would have had that, he would have been around for my kids a little bit longer, right? So that's my why. Like, that's huge. I mean, that changes somebody's life, especially a diabetic, because a lot of your symptoms and your problems don't come till a lot later in life. And this is our hypertensive population. Again, it shows who's in our program and who is not. In our remote monitored program that is run by our community health workers, they're not run by our MAs, it's run by the community health workers. We can see that improvement in that population has been growing steadily. In the last quarter, they've improved 8%. And I looked at my Azara before I presented, because I just wanted to see, because, you know, as we add people, it ebbs and flows. They increased another 4% this last month. Like, that's huge, right? That is a success for everybody. And that's because we have tried to create this trust. So if you're scared of data, or if it makes you feel a little bit hesitant when someone's asking for that, this is why, because it buys trust in with our providers. So again, just a little bit of that. And we also, our CHWs work within the EHR, and they have a template that helps them to document SDOHs. So we're able to look at our outreach efforts and the way that we're doing things, and we're able to say, hey, look, we're doing really well with this population, but we're really lacking in our uninsured population. Maybe we need to get them on the sliding fee scale. Maybe that's a barrier for, it helps to inform those decisions. So I think when we share that information, like I said, providers want to help their patients, but we have to tell them why they need to help us. And so I would encourage you, if that's a barrier for you at all, to ask your CEO. The most brilliant thing I think our CEO did when he brought on my position is my supervisor is our CMO. Is not the director of operations, is not our COO. I am under the CMO. And I know that, at first I was like, that doesn't really make sense because we're doing community stuff, but it's been a beautiful relationship because it leads to communication. So, we kind of talked about the EMR tasking. Our CHWs are in the EMR, but we also have these grant committees. We have a couple of different grants. Do you mind if I grab some more? I get kind of I talk really fast sometimes, and sorry, just a second. Thank you. So we have providers that sit in on my grant committee, and not just for care coordination. We do that for community outreach and for community access. And we listen to their input. And I think that that has made them feel empowered to have a voice, because I think they're just very protective of their patients. But when they see what we're trying to do, they're willing to bring more. So if you have committees of some sort, I love committees because it's like a little party with all your friends. Use them, please use them. And then the monthly meetings. I sit in on that provider meeting every month. My CMO makes sure that I have 10 minutes to talk, to have them ask questions, to share this information with them. And then I take their feedback and I make sure that any questions that they had that I couldn't answer, I come back and I give them that answer. I make sure that they feel well-informed and that they don't feel like I'm talking at them. It's really a conversation. So, it's like I said, we're building that trust. And then we do lunch and learns. Our CHWs, again, who doesn't love food? They go and they have lunch and learns in our clinics with providers. And sometimes they share some things about their programs. And then sometimes we ask the doctors to share things about their programs. And it really becomes a collaboration of both of our teams. And it's what it's supposed to be, right? We're supposed to be a community. And I feel like your work is your community too. And we have to build that first, because if we're not building that, we're not helping anybody. We're staying in our silos, and that doesn't serve anybody, because then people are having to go to different avenues to get the help that they need. So some surveys. So we have surveys where we, for not only our patients, we ask our patients how the programs are going, how the CHW outreach is, how they feel like we could communicate better, how the community asset map, is that helpful? What do you wish that we had on there? Those types of things. But we also survey our providers. We ask them, what can we be doing better in? We ask them, how is the CHW communicating with you? How can that improve? And then we ask them for their ideas. Like, who in this room doesn't love when someone asks them for their idea? Like, is there anybody in here? I think most of us love it when someone says, what do you think? And then they give you time to answer, and then they do what they can to integrate your answer into what they're doing, right? Because if not, you just feel like you're just being talked at. I still have 5 minutes. Again, it goes back to like this middle child thing where I feel like I have to get through really fast because somebody might take like my food or my time. So I don't know how many more slides I have, but we'll see. We might be able to do it. I'm so passionate about teamwork. And I feel like we talk about it a lot, but we don't talk about it as a holistic whole approach, and I think that I was a little bit nervous about my presentation, because I was like, man, it's not going to be just all CHW stuff, or it's not going to be all just one thing, but it's because we already know what brought us here, right? We know what our jobs are. We all know why we're, what we're doing here, but why are we here? And I think the why is because we want to change a little bit. I don't want to walk away from this conference feeling like, well, I already knew all of that stuff, and how can I make myself better? And luckily for me, I'm so new in this that I know nothing. So everything, my notebook, I'm like, oh yeah, that's a really great idea. I should do that too. So I'm very fortunate that way, that I'm still so new to this, and I have so much to learn. And, we are so fortunate. I think it was Maya that actually mentioned that it was a female workforce. And I think how wonderful to see. And not that the poor men in the room, I think like 3 of you. Great. But as someone that came from a family of all women, except for my poor father, women can change the world, right? And I just love knowing that that's what we're doing. Women that are coming off of, and that's why I feel like the certification is so important, because so many women, they manage their homes, right? They manage their kids. They don't have the opportunity to go back to school sometimes the way that males are. And that's just that's just how it is. And the fact that we're talking about this certification, I feel like brings value to what women have been doing for centuries, right? They have been healing communities, they've been healing families, and they've been healing hearts and rifts that have existed. And acknowledging that helps to kind of start to bring some healing back to, I feel like as women, sometimes we feel like we're undervalued. And so I love that that's coming back. And sorry, I go on my feminist rant and I need to stop. You can kick me off anytime you want. You guys can go through all these slides. We do have challenges, you know, like it's a new program and it's not perfect. And I'm very fortunate that I have 4 amazing CHWs that I see growing into roles in leadership within a CHW organization umbrella. You know, we've written them into grants, and I want it to grow and I want it to be sustainable. And I feel like that starts with me sitting at the table and listening. You know, I want someone to listen to me and why my program's important. And I think it's really important that we start getting to the table and acknowledging that what the clinical team is doing is also really important. And they also want the same thing that we want, right? They want their patients to be healthy. They want them to live long lives. So let's do it together. Let's figure out our why. And I'll leave you just with a couple thoughts once I get through a couple of my slides. Here we go. I love Maya Angelou. I feel like if I can't say it, then I need someone to say it better for me. And that's usually why people end with quotes, right? Because someone else has already said it better. So we're just going to go with her. And I have learned that people will forget what you said. They will forget what you did, but people will never forget the way they made you feel. And I hope that when you leave this conference today, that you feel empowered to decide how you are going to make a difference, how you as a single person is going to infect change into your community. Infect's probably not the right word, but your effect change into your community, because it only takes one person to start that, right? And please, you know, reach out to me if you have questions. I'm happy to help. Like I said, I am not an expert on any of this stuff. I am very much so just a thank you for inviting me. Like, I'm so excited to be at the party type of thing, you know, because you know, I'm just not on the same level as some of these people, and that's okay. Like, I'm okay with that. But make sure that when you're making people feel heard, that you're making people feel included and needed, and that's when you will see the change, and that's when you will discover your why, and then the possibilities will be endless. And thank you. And I'm going to turn the time over to JT to bring us back on the track. Thank you.
Should have wear heels today. Now remind me again.
Oh, it's the middle one here.
Okay. Good afternoon, everybody. My name is JT Nashio. I am the CHR Program Director for the White Mountain Apache Tribe. A little bit about myself. I actually started in the field as a CHR CNA, and then just worked my way up being the CHR lead and doing a little bit more case management with you know, the different departments within our tribe. And then also doing some supervisor management role for our sister program, the Apache Diabetes Wellness Center. And then coming back to CHR, and then now the program director. I've been with the program for 11, going on 12 years now. And so definitely still excited to learn and continue servicing the people the best way I can. And so this is the CHR program. This is our latest picture that we took as a group. We actually started with about 15 CHRs in general. And then when COVID happened, we had to grow and, you know, and respond in that manner. And so we went and doubled our employees, and then now kind of dwindling down. And now we are about a team of 20. We have 2 locations. There's the Cibique and White River location. And so there's Cibique is about 45-minute drive from White River. It's in a rural area, and it's one way in, one way out, but definitely one of our areas that we serve on the reservation. So a lot of words. So basically, the White Mountain Apache Tribe Community Health Representative Program strives to raise the level of awareness and promote a healthier lifestyle among the community members of the White Mountain Apache Tribe. Surveys of Native American health issues found that many health disparities among community residents needed a program which services specifically designed toward tribal situations. The CHR program has been a familiar part of the healthcare system, and the CHRs have become an important liaison between the community and Indian Health Services. The White Mountain Apache program is located on the Fort Apache Indian Reservation, which consists of 1.67 million acres over 2,600 square miles in East Central Arizona. So we service a wide area. Our population is pretty significant as far as who we serve in our area. The White Mountain Apache tribe now consists of approximately 16,000 tribal members, those of course who live on and off reservation. Once again, I can't highlight enough about what the program does overall. The program was implemented to improve health, knowledge, attitudes, and practices of Indian people by promoting, supporting, and assisting the IHS in delivering a total healthcare program. The efforts of CHR program staff have produced an American Indian and Alaskan Native Health Service delivery system, which provides for the follow-up and continued contact with Indian healthcare delivery system at the community level. So we're definitely community-based. Majority of the CHRs that work for the CHR program all live in the community, are born and raised, and are a part of the community. So we do service a lot of our own members and do so in a passionate manner. The goal of the CHR program is to address healthcare needs, of course. And as you heard in the prior presentations, it's basically being that bridge, but also the main thing and one thing that we've all had a passion for is basically service. We are of service to our people. So, of course, you know, there's always that question of what is the CHR and what is the CHW and what is a promotoris? And so in 1968, under the Office of Economic Opportunity, surveys were conducted on health issues. These surveys identified many health concerns among Native Americans in need of a program to provide service relevant to Native cultures and languages. Based on this need, the community health representatives evolved in Native country. In the 1970s, Alaska tribes requested for a CHR program with Indian Health Services. The IHS receives the funding and dispersed to all tribes to function as a tribal program. The CHRs have become an important liaison between the community and the IHS. To date, there are over 1,400 CHRs serving over 250 tribes in the United States. So when you ask, what is a CHR? A CHR provides healthcare, health, education, and wellness activities in a group setting, an individual setting, and in communities. I'm sorry, the wording is so close, I cannot read off of that. But like I said, there's so much that we do. And, you know, one of the main things that a CHR is very, I guess, strengthening in, one of our strengths is being a jack of all trades. You know, there's so much that we do. We have different certifications under our belt as a CHR. There's food handlers, there's the first aid, CPR. There's, you know, I've had a few who have taken the car seat trainings because we work with the schools as well. And so when you ask a CHR, what is it that a CHR does? You know, what is a CHR? And one of the answers you'll hear is, I am a health educating, case finding, screening, interpreting, translating, community developing, advocating, health fair conducting, injury controlling, socioeconomic connecting, exercise leading, health promoting, emergency responding, CHR PCC documenting, patient monitoring, listening, and caring tribal CHR. So that's basically what a CHR is. You know, there's so much that we can respond to. There's so much that we can do. And it's because of how well we know our community. The CHR program is, one of the unique things is the CHR program is built based on the needs of the community. So each CHR program is unique in its own way. I just want to take some time to recognize some of our CHR champs, is what we would refer to them, because they've been with the program for a very long time. And, you know, we've heard conversations early in the prior presentations about funding for CHRs. You know, I've have CHRs who have been working and servicing their community and making a difference for so many years, and, you know, not having much of a raise in an increase in salary. But the fact that they're still there and working for so long definitely says something about the type of work that they enjoy doing, the difference that they enjoy, you know, making in the community. And so there's LaRue Truax, who's been with the program for 40 years. Robert Colson in the middle, he's been with the program for 37 years. And then Kathy Ethelbaugh, who has been with the program for 42 years to date. And they are all still working with the program now. And so once again, CHR services include a variety of things: health educating, case management, case find, patient monitor, home health care services, school presentations. We're very involved in our schools. We have an MOU with the school district, which is 1 high school, 1 junior high, and 3 elementaries. There's a few other smaller schools, BIA schools, which we also do provide presentations with. We do, a lot of the CHRs can speak and understand the language also. So that's very, very important as far as the people that we serve, because we're able to educate and talk in our own language about different things when we, especially when it comes to their health. There's a way that we can try to explain it and get them to understand. And that's something that the providers, you know, really reach out to us for. So as I mentioned earlier, each CHR program is built based on the needs of the community. One of the programs that we house in the CHR program or on White Mountain is the White Mountain Rocky Mountain Spotted Fever Prevention Program. And there's the mission statement, but it's to reduce cases of RMSF among tribal residents by community education, tick reduction, and basic veterinary care and control. So we have RMSF officers who work on prevention services in regards to Rocky Mountain Spotted Fever. Does anybody know or have heard of that term? Okay. And so the program goals, reducing the burden of ticks and owned dogs on the Fort Apache Indian Reservation, reduce the burden of ticks in and around home sites on the Fort Apache Indian Reservation, improve access to animal wellness clinics and spay-neuter capabilities for tribal residents, increase community awareness of RMSF prevention techniques, establish a sustained animal control program on the Fort Apache Indian Reservation. So RMSF in general, hoping to build that foundation to an animal control program, which is something that we do not have on our reservation currently. But through grant work, we were able to start, you know, laying that foundation. And now we have 2 animal control officers who are, you know, guiding the way and doing some of the work, reviewing the animal control ordinance, and, you know, just putting forward their prevention efforts alongside our RMSF officers. Once again, RMSF prevention efforts, because we are a prevention team, we received a grant from the CDC. We hold spay-neuter clinics throughout the White River and Cibecue community. We hold pesticide campaigns, which are done every 6 weeks. They usually start in May and end in September. There's the euthanasia contract, which we have with a sister program. Well, actually, it's a neighboring town, collaborative efforts, also with the animal control program, which is what we're starting up. And so this is all work that's done right now off of a 4-man team. And then just utilizing that collaborative efforts and resources in the community as far as creating partnerships, creating MOUs, and, you know, identifying policies as far as how we're going to carry out that effort. And then, of course, COVID-19. That I just have to admit, I'm a little nervous right now because this is my first presentation in 2.5 years since COVID hit, and realizing how important the program is, how much of a difference it is in the community, really reminded me of how important it is to, be a part of these boards and, talk to Access and talk to, different people as far as this workforce. So back when COVID happened, because of how well we're embedded into the community, because of how well we know our area, I was actually placed as the operations section chief under our emergency response team for our tribe in response to COVID. And so I oversaw the operations. And in overseeing this, one of the things that we did was build a team which basically supported all patients on the Fort Apache Indian Reservation throughout their quarantine time. And this was services as far as delivering supplies, whether it be food boxes, medical supplies, connecting them with the different resources that were open, daily home visits. It was also part of our job to ensure that quarantine was being followed. And back then it was for 14 days. And we worked weekends and we had to go and do home visits every day throughout their 14 days to ensure that, people were abiding by quarantine, that they were okay, that there was no more further testing that was needed. And even if there was, we had to follow them through. And we've had families who were in quarantine for about a month because a lot of our homes were so intergenerational where there were multiple families in one household. So, it would extend their quarantine time. And for that whole month, CHRs, PHNs, and IJust providers were servicing, these families. And it was, sometimes we didn't always have a food box. We didn't have it from the very start of COVID. And so we actually offered grocery shopping. There were a few times when a few of the CHRs had put some of their own personal funds together to support these families. Excuse me, I'm getting emotional. But, it's the team, the service that we provide. It was really special. It was really needed. And it was definitely something that the CHR program was able to do during the last 2 years, and today still doing as I'm giving this presentation. And so just a few pictures to give you an idea of the different things that the COVID team did. We have a picture with our high-risk team. So we developed a high-risk team with IHS and basically identified all those patients who tested positive and who were categorized as a high-risk patient. And they did daily follow-ups. There were meetings daily, meetings on the weekend where they were attended a briefing. They were given their case lists, and sometimes it was 10 to 15 pages of patients, and they'd come together and they'd do their case management, they'd review their cases, and then they'd go out and do these home visits. And an IHS facility isn't a facility that offers emergency services. We do have an ER, but if we have somebody who is needing a lot of service as far as care, we'd have to fly them out. And we all know that a lot of the hospitals were full during these times. And so we had a high-risk team that would do follow-up. And being that this was a respiratory issue, it was just a matter of checking the oxygen levels, understanding their health, and doing what we can to provide help early on so that they wouldn't get so sick, so that they would have to be flown out. And so that's one of the efforts that really kept our death rate down, I guess, so to speak, because they predicted that we'd have a very high death rate due to the area that we're at, the medical facility in our area. and the amount of people on our reservation. And so we were able to keep our death rate fairly low due to the great work that the high-risk team had done. Another interesting job of the CHR was quarantine homes and placarding. How many of you are aware of what placarding is? So I have CHRs in the middle raising their hands because I'm sure they've all done this at one time. Or you basically go to the home and you tell them, okay, you test positive, you're under quarantine now, you cannot leave your home for 14 days. And because you have an infectious disease, which this is written in our health code for our tribe, we have to placard your house, meaning we're going to put this shiny yellow sign up that tells your neighbors, you're under quarantine, you can't have visitors and you cannot leave. And that was definitely a tough job for the CHRs to do. But today it's still being done. And it was a change that wasn't liked much, but it was really for the safety of the people and for the safety of the community. Also, another thing on our reservation, which we did during COVID, was we had reservation lockdowns. So we actually did lock down the whole reservation at a point. I believe we've had 5 total, and 2 which actually were, I want to say, at least 4 weeks based on the increases that were happening on our reservation. There's our COVID team. So we've gotten testing, N95 fit testing. We've got the donning and doffing of PPE. We're trained on how to swab and carry out those services. And so the team that we built, we're all trained to do all these things. When we started to understand a little bit more about COVID and how we're going to respond as a team, the CHR program started doing department testings because work still had to continue for the tribe to operate. And so people had to go back to work, and to ensure that there was some safety in that regard, we offered to do department testing. And then also we chaperoned our providers. As you've heard earlier, one of the things that we do is translate. And so we even get referrals that tell us to locate a patient. And that's it. When you locate them, call me. And that's it. Like that's how well we know our community. That's how well we know our community. And so we would chaperone the providers, so-and-so's here. Who's on your list today? This person, this person, this person. And the CHR is going through saying, okay, we're going to start here, then we're going to go here, and coordinating those services. And so there's a training that I mentioned earlier that we had to get done. And so I say, Ashok, thank you. That's the CHR program. Like I said, I'm a little bit nervous, but it's definitely exciting to be here because this is my first presentation after the 2 crazy years we've had. But it's definitely exciting because I get to see all of you, and being up here and speaking to all of you about, the workforce in general is just like a kickstart and a reminder of why I'm standing here today. Thank you.
Wow. Okay. Well, I promised that it would be good, and they came through. So that's pretty exciting. And I imagine that I was just thinking about, wow, if I was going to do a word cloud as I was sitting there listening, and then my word cloud got bigger and bigger. But I heard, community, and I heard bridge, and then I heard, data, and then I heard communication, and I heard a lot about caring. And so these are things that I think we would probably say were common across all of these programs, but they're also really different, right? And they're figuring out how to fund themselves in really different ways. I was a little bit struck by the clinical side. You can see that they're maneuvering through these value-based purchasing opportunities, but when you hear the word, when it's primary prevention, you're hearing a little bit more about grant funding and how some of that is more temporary, these kind of innovative ideas coming out. But I think that there's lessons to be be learned from all 4 of these programs. And so I want to provide an opportunity for you all to ask questions, and we can have a little bit of discussions and have each of these folks share a little bit more about the kind of things you didn't hear, because this was obviously an overview, and so some great history, right? Some history that I hadn't heard before about these programs. So please, those of you who are out in the Etherland, put your questions into the comment. And those of you that want to ask a question, there's a microphone there. And I was thinking maybe I do have questions, so I can ask questions for as long as you all want me to ask them. But I thought maybe we could start out a little bit talking. So we've talked about sustainability, right? We've talked about reimbursement, but that's almost just for the workforce itself. But for each individual CHW, when they start off as a CHW, they have a whole career and life ahead of them. So how do you all think about the CHW workforce in terms of promotion, in terms of a lifetime commitment to the field? How do you think about promotion and job opportunity within each of your organizations in terms of their job trajectory? And I invite just anybody who wants to start just to go ahead. We got some new programs, we got some older programs. You can start with Mariposa? Yeah,
Yes.
okay, sounds good. Is it already on? Yeah, it's on.
Well, we just want to say that we're planning on expanding behavioral health services at Mariposa. So that's coming on soon. So I know that they're going to maybe get a model like us, meaning they're going to get I believe it's called behavioral health integration.
It's not our department.
No, no, but we know that they want to like get one of my coordinators.
It's like expanding the services of the care coordination team within the behavioral health realm of our, in addition to our clinical services.
Yes, that's where I was going. Thank you, Patty.
Yeah, for the most part, I mean, we offer opportunities for all of our CHWs to grow into different positions. We've had many that have grown from a CHW to coordinator to even managing some programs and services within the clinic. So there are various opportunities for them to grow. We have many of them who themselves just come out and really promote what they're doing, and they're pretty much born and raised from the different programs that they themselves participated in, and that is something that we look forward to, and when we're looking at what makes a really good community health worker.
Well, for us, we started, I was the first CHW for Equality Health, and then we started growing the program. And as we were recruiting, we were having a lot of people applying, and we realized that we were contracting with people that had experience as CHWs, with some other folks that did not have previous experience as CHWs. Maybe some had bachelor's and had formal educations. We even had a master's degree that wanted to be a CHW. And so you really have to start and meet those individuals where they are at, in what path they are at in their personal and professional development. But we did realize as we were growing that we all want to grow, and they also want to grow. So we were finding the needs, and we had to adjust our program as well. So now we are in the process of creating tiers for the CHWs, because we know that they want a growth, a path that they are going to grow professionally, and depending where they are at, as I said, those that have that master's in public health, then they know that their growth is going to be perhaps managing another CHW program or creating something else. But those that are had the experience, had not the formal education, are looking into ways to acquire that training, formal training, and then continue to grow on the path. So there's some that want to grow out of the department, and they want to do different things because they can see that now they have all these skills that they can take and use somewhere else, but there are some that want to continue to grow within the workforce of CHWs, and that we are supporting that growth and creating those opportunities for them. And we are also thinking about the behavioral health. How can we do that behavioral health, that social work in that clinical?
Sounds like behavioral health might come up a little bit more. JT or Jody, do either of you want to respond to that, or?
I guess in terms of expanding and recruiting, and I guess what's worked for our area is grant writing and advocacy at the state level. You know, being involved and always looking for opportunity, especially when you're wanting to grow a program, and especially if it's when you find individuals who have that passion to serve the community. And so lately, at what I've noticed anyway, is the best way would be for us at this point right now is just to continue to advocate and be involved at the state level, then also always searching for grant opportunity. There's money out there, you just got to find it.
I'll pitch in here just real quick. At being new, I think really what we're doing is we're looking at more established programs and just trying to model off of them, as well as, you know, I sit down with my CHWs and I regularly sit with them and see what their goals are.
Chaplain.
Did the nurses come?
Yeah.
They were just agreeing with everything I was saying. Thank you so much. You know, I sit with them and I let them have a voice as well. And I think that, you know, and I ask them what their aspirations are. And then you know, my goal as a supervisor and also as a teammate and friend is to make sure that they're growing, even if maybe if it's not with their company, that they feel as a person that they're growing, because that's the most valuable piece to me. And I think that that's kind of what we're working on right now. Maybe in like 2 or 3 years, I can answer that question more fully.
Wow, though, you know, a couple of you are bringing up the importance of CHW supervisors and your role as CHWs yourselves, but maybe some of you not being CHWs, and how important that is to bring sort of that knowledge in terms of mentorship and helping folks identify where they want to go. So why don't we turn over to some questions in the audience? It looks like Kim has a question.
Great presentations, ladies. Thank you. My question is around, well, we heard earlier today about the voluntary certification and how that's going to lead to Medicaid reimbursement. For all of your programs, what kind of training or technical assistance do you think you're going to need when that's here? So I'm wondering, so just to kind of expand on my question a little bit, are your systems already kind of set up so that when Medicaid reimbursement is reality, you can start doing that? Again, really, what does that training and technical assistance need that you might have or that you're foreseeing right now?
For Canyonlands, we're similar to Mariposa. We're also an FQHC, so we're very limited in how that reimbursement is going to look. And so right now we're still looking at, you know, grant. You know, I submit grants regularly because that's the only, you know, I don't really know where else we can go from that until, you know, and I feel so bad because Access is like right there. I'm not like blaming you guys. No pressure. I'll send you some food if you can make it work out though. But so I kind of, we don't really have anything that we can do much with that at this point. Our commercial payers, there's might be more, and there's some more value-based type things that we can do, but I'll send cookies.
Well, if I can add, we do have shared savings. So those that I shared earlier, because we do get the hospital. I mean, patients out of the hospital on the long run. That's how we generate revenue, but we cannot do it as a daily basis because we're not at an RN level. But at least, you know, all the services that we're doing, we're trying to come up with. Because I forgot to mention that we're under population health now. So we're trying to do the CCM program, which is chronic care management. And that's how we can get reimbursed per patient per month. So that's what we're heading towards right now, but it's still in the works. Hopefully that makes sense.
Do you have any thoughts, Nora, about certification and getting ready?
Well, the AC Chow provides already technical assistance. I can only think that if, depending on what codes or what is that we're going to be allowed to bill for, then I think that we're going to be identifying those needs. But if we're going to do case management and all those more clinical what we're going to be able to assess, because now we're not able to assess, we're just screening, or if we're going to be connecting SDOH and we're going to be able to build for C codes that are tied to those social determinants of health, then probably there is going to be opportunities for technical assistance. That's what I can think at this moment.
JT, do you have anything you it's kind of kind of relevant to all the organizations. So I want to give you all a chance to respond if you have something to say.
Okay. I think as far as training, having a little bit more wide variety on the types of training that's needed to service each community. Like I said, CHRs are built based on the needs of the community. And then with the technical assistance, I think one of the main things at this point for a lot of the CHR tribes or CHR programs is not necessarily having a place within a medical or IHS facility to allow us to do our data entry. You know, we're required to document 480 minutes a day on average, and you know, we have to get that into data mart, which is what tells us what services that we're dominant in, which services we're, you know, a little bit less dominant in. But if we don't have a place that's offered to us, you know, daily when we're supposed to be working, then, you know, how is that supporting each of our programs as far as putting our data in? We collect it, but not having a secure place to be able to do that is something that is very challenging for a lot of the CHR programs.
If I could just expand on Kim's question a little bit, because I was thinking about you all getting prepared and thinking about reimbursement and how we, you know, how we sustain these programs. But a lot of the reasons that I heard from community health workers back when we started the process in 2012 or 2011 or 2009 or whenever that was really the desire for recognition and for what they did, and then sort of the standardization across programs. Is there some, apart from the reimbursement piece, is there any reflections you all have in terms of the importance of that and how organizations might think about it? If it's not like direct reimbursement, however you recognize how it can help serve the needs of your sort of organization. Does that make sense as a question?
So I can kind of help with that, just because with the CHW organization or department that I oversee, I have many CHWs in the organization that have been there for a really long time. Like I said, the organization's, the department has only been around for 31 years. I have CHWs within the department that have been around for that long. For them, they are the ones that they have an entire binder with that certificate for every single training that they have ever gone to, attended, and received. And for them, that is huge. So they are proud. They'll carry it around and like, look, I have this, I have this, I have this, I have this, I have this. So they may not have formal education. They may not have gone past high school. And the reality of it is the work that they're doing is quality work because of the trainings that they've received, the knowledge that they've gained, and because of the different type of professional development that they have received, such as all of this. And from the focus of my department being 100% grant funded, when I'm out there seeking funds, whether it's federal, state, or private foundation funds, I write my CHWs into the budgets, into every single grant. And I highlight the different trainings that they've had, especially if it helps to gain that funding source for whatever project it is that I'm going out there for. So it's important. Those certifications are important. They're proud. They're proud of that. They're proud of what they've gained in the knowledge. And they walk around with these binders. It's like their little Bible, you know. So.
And just to add
Hello. Okay. To add to what Kim was asking, as you all are talking, some of the community health workers that I've worked in the past, they have the knowledge, they have the experience, they have the passion, the compassion, the will, and sometimes the technology has gone farther than they have. So I think that one of the technical assistance that it can be is technology, to bring them up to date with the technology, because being needing to access health records and all these things, and putting the documentation that she's talking about, that you have to document, sometimes they don't have and have not, because of those health disparities and social disparities, they haven't had the opportunity to have that formal education, and they don't have the access to that technology, even though they are doing the work out there. So I think that technology is a big one.
I don't know that I could say it any better than, I mean, I think it brings, people like to feel recognized. And I think whether we're being reimbursed or not, I think we know that the CHW and the work that the CHRs are doing, and they're not doing for reimbursement on their own part. They do it because they love their communities and they love serving and they love helping. And I think validating that is monumental.
Thank you. So I know we also had maybe some questions online, or not, I don't know, call it online.
Yes, it looks like we have 3 that have come
Okay,
in.
we'll just
We'll start
hand it
with the
over to you.
first one from Jack. Is anyone coordinating CHW training and development with other systems like AZ at Work, workforce development boards, school-based healthcare alliance, and access claiming, behavioral health peer specialist programs, and prevention initiatives through the Department of Education?
So the only one of those that I could possibly address is school-based healthcare. And not specific to school-based healthcare. We were doing some training with CHWs to do school-based and community linkages and linking students to services and referral services that they might need within the scope of their health and well-being, and connecting them to primary care as needed. And now what we're doing now is school-based telemed. And we have MOUs in place with the 2 largest school districts within our county, so that we're able to, we have computer system set up in a private room so that we're able to do telemed, the consent forms with the parents and the families. And so the CHWs were kind of doing, kind of leading a lot of that by getting all that paperwork and working with the school districts and the school nurses and going through the trainings and ensuring that they have all their T's crossed and their I's dotted and everything else that was needed. So, but that's as far as in terms of that question right there for me.
Anybody else? Anybody in the room have any responses to that question? I don't know if you want to grab a microphone.
Hello, Maria Chaboya from Yuma with Arizona Complete Health. We do work with Arizona at Work in Yuma County. We do have the TPL already established with Arizona at Work and the college. So hopefully, so that it is a state approved program. So it is possible. It may work easier in Yuma because I'm on that board also. So it helps our process to make sure that our CHWs that are going through the training do get that through Arizona at Work. So it's a long process, but it does happen.
It sounds like another model we could learn about, maybe another conference. If there's no one else, we can try the next question.
Yeah. Hi, wonderful panel today. Erin Guest, Assistant Professor in Aging in the Center of Innovation and Healthy and Resilient Aging at ASU. When thinking about continuing education opportunities around CHW and our aging population, are there any identified needs? Is this an area CHW needs additional information in?
Go ahead.
We, is this the same, similar to, was it Belinda that did a training for us on kind of like caretaking and stuff? And I think I think she was with ASU, but I do think that it's a lot of, I think it was mentioned in an earlier presentation, there's a lot of multi-generational families living together. And I think providing that information is something that we need, and having additional trainings on that, because anytime that you're working with an aging population, you're going to be hitting chronic diseases, you're going to be hitting dementia and Alzheimer's. It's the Alzheimer's one. That's what I was thinking of. That's what,
Did you forget that?
I forgot that. I was like, I felt familiar. So yeah, I think that would be great. So yeah.
So at Mariposa, we actually worked with the GWEP program with the University of Arizona with Dr. Mindy Fain, and a group of people from the University of Arizona came down and trained the CHWs in empathy training, and there was a whole bunch of others, and so that they were able to utilize that training to work with the older adult population. We also have an elder wellness network where it's all older adult working organizations within our county that we disseminate information, share information, do a lot of info sharing. We work with our local SEGO and
I'm here whispering everything. I mean,
so all the older adults serving organizations in the county, and we're able to disseminate all this information to them so that they're able to utilize that and make it to their benefit. And I forgot what the whole point of the question was.
Oh, it was just around.
Oh, no, Elder Wellness Network. So we did a needs and gaps assessment. And so we have that in place. And so if anybody ever wants to come to Santa Cruz County to help us with our older adult population, we do have a needs and gaps assessment that was done and put together. And so that's there, and it's just kind of sitting there. But COVID did happen like right after that. So we haven't really been able to do a lot with it.
So the question is about, what needs have you identified in your communities around elder care, and what kind of trainings might you be interested in for CHWs? Does anybody else want to respond?
I would say maybe advanced directives, because there's been a lot of questioning about whether or not you have to have it certified or not. If you can just like, oh yeah, you can go to the home and explain all the different forms, but I mean, does it have to be certified? That's the big concern that comes up, because us, when we go and do all this, we do discuss this, but we don't get the forms back. We might get the DNR that do not resuscitate, but not the other ones. And, elderly, we've been noticing a lot of dementia, a lot of Alzheimer's, where they're not able to make decisions by themselves. But we don't have advanced directives, so it's been getting tricky. So if we get some training like that, that would be awesome.
And just to piggyback with that, depending on the culture it's different in different cultures, but making that decision and that advanced planning and informing the whole family, the whole support system on when it's appropriate to have hospice and palliative, and what does it mean, and what options do you have, and what is home health, and those advanced directives, and ageism. Am I pronouncing it correctly? Mm-hmm. Yes. So because sometimes even though we are very loving cultures, we also discriminate our elders. So raising that awareness and training those community health workers to identify and bring the awareness out in the communities about these issues, I think it would be a great addition to the training.
Those are great suggestions. JT, do you have any suggestions from your community, or you want to pass on this? It's completely up to you. I know you have a lot to say.
I think when it comes to, repeating the question, is it how can we?
Well, they were asking about what you feel then are there needs of the elders in your community that are, distinct from other needs that you have, and that are there CHW training needs around care for the elderly?
I guess and I'm just speaking from our area, just basically keeping a CHR involved throughout the whole process, because the CHR, knows the resources in the community. And then, within our IHS facility, there's staff changeover too. So there's new providers and old providers. And, we don't know how they identify their patients, but when they do, just keeping us involved so that we can give them a better understanding of, like our PCMH meetings that recently started up again. And so, we're basically, we're that bridge, basically, just keep us involved. That's the main thing all the way through.
No, that's great. Okay. And I know we have another online question, but I just want to make sure some of us in the room have a chance. Maya, did you want to ask a question?
Hi, my name is Maya Blockengaibe. I work at the Center for Rural Health project called AZ COVID Text, our Rural Health, texting messaging system that's promoting text information around COVID-19 and resilience. And so I had a question for all of you, but also kind of spurred by Nora's point about spirituality as well. So it's a two-part question, first about resilience and then also about spirituality. But I was wondering how you've been promoting resilience in your own communities, both on an individual level, for example, among your community health workers and the healthcare workforce in your communities, and then also as a community, and then also perhaps within the healthcare system level. I know that there's been a lot of burnout, for instance, on the individual end, especially with COVID-19, and there's been a lot of stresses. So I know there's been also a lot of talk about building resilience so that we can be able to be prepared for the next pandemic or whatever else, next shock it might be that comes along. So I was wondering what you're doing on that level. And then also when it comes to spirituality, I think Nora was the only one who really mentioned that, but I wanted to hear a little bit more about how you are able to promote spiritual health in an inclusive way. I know you mentioned the chaplains. Are they from different religions or just from one type of religion? And then also if any of you, the rest of you are also promoting spiritual health, how do you do so? So I know, sorry, two questions.
Two complex questions.
Hello. Okay. So for the resiliency, I think that one of the core competencies that we utilize, at least my team and I, is the capacity building. We empower the members that we work with education on how to access those resources themselves. So often we even do three-way calls with them so we can kind of coach them and mentor on how we are accessing those resources. So the next time that we might not be available, they know how to go and do self-advocacy, right? That's one of the resiliency parts. Now, to respond to the spirituality, our chaplains are non-denominational. And so when we are screening for social determinants of health, we do have a specific questions that we ask about support system and if their health and life situation is affecting their spiritual self. And when we get a positive response of, yes, I feel like this or that, then we introduce the topic of, hey, we do have chaplains that are able to talk to you regardless of what spiritual belief you have, regardless of what religion you follow. They are able to assist you. We do collect the information of what they prefer, what are their preferences. And so when we connect them and do the referral with the chaplain, we provide that information so they respect and honor that that belief, right? And they are already approaching them through that lens of that particular religion. Or we have even had situations that they don't believe in anything, but they do want to talk to somebody about how they feel. And our chaplains are open to do that. You don't have to believe in anything. They are here to support you, to give you hope in whatever it is that you believe. So that's how we approach it. And for every person that we engage, we do ask those questions. So everybody has the opportunity, and sometimes they're hesitant, like, no, I already have a connection with my church or this or that. We kind of push it a little bit, the envelope, and we're like, give it a try. It's a phone call. If you don't like it, he won't call you back. And normally those relationships get stronger, and our chaplains can, have that relationship with them for as long as they need it. So it's really neat. They are very, very popular members of our team.
It's really an interesting aspect. And I know that CHWs as well has worked a lot around spiritualities, and there's definitely other folks in the room you could talk to. You know, I encourage everybody to reach out to these four. You'll have their information. Afterwards, you have their bios. Talk to them specifically about their programs. I don't want to cut any time away from our final speakers, because those are our words of inspiration going forward. So I'm sorry that we didn't get to all of the questions, but they are here. They are part of our community. They're committed to our community, and they gave us a wonderful glimpse of how to create programs. So let's give them a round of applause, and thank you all for your questions.
We'll bring you back for our last 15 minutes, and then we'll let you continue your conversations and all of the cool things that you want to talk about and all the changes you're going to make based on everything you've heard today. So I can't say enough about the next three speakers that are joining us. For me personally, I've known all three for many years, almost 20. And I learned about community health workers and community health representatives from these three women that will be sharing their last kind of call to action and inspirational message with you. So I was 28 years old when I met Flor working, she is in Yuma working with farm workers, and I had a little blue Geo Metro and drove myself from Tucson to Yuma to learn what a promotora was and how they were serving agricultural workers in that region. I met Jill. She was the Associate Dean for Community Engagement at the U of A, and everybody said, you need to talk to Jill. Go talk to Jill. So Jill is one of those promotoras or community health workers in a university where she's the one that you go to figure out how to do the thing you want to do and how to reach the people and how to find the money to do it. And then Majeline Begay, who is calling in. She will pop up in a minute. There she is. Majeline is really who taught me about CHRs. Majeline was the director of the Navajo Nation CHR program, among many other things, for almost 21 years. And she led that program over 110 CHRs during the global pandemic. And I will never forget going out to Majeline's trailer and sitting with her CHRs in Window Rock, watching the snow fall and fall and fall, and thinking, I think I'm going to sleep in this trailer, and all of us are going to sleep here. And I just appreciate each of these incredible leaders, advocates, people in getting us to where we are today and being able to have this beautiful time together, because they are essential to it and fundamentally a core part of it. So I'm going to welcome Jill DeSepien, who will speak first, and then Majeline Begay will speak, and then we'll close it out with Flor Redondo at the end.
Hi, everyone. So nice to be here, and I will try to keep it short. But I just wanted to start out by saying, isn't it odd? Did you listen to that incredible panel of all of the things that community health workers are doing in this state? I mean, you just sit there and listen and think, how is it possible that we're one of the only countries in the world that doesn't realize to have health in our communities, our healthcare system has to include community health workers? I mean, it's just bizarre, no? I mean, you look around the world and you see all these other countries where they're integral parts of the healthcare system. And all you had to do was listen to the panel that Maya was moderating and hear all the wonderful stories about everything that they're doing. And you think, what's wrong with this picture? You know, it really strikes me that it's such a contradiction in terms of what people think of when they think of, you know, the United States of America and their wonderful healthcare system, et cetera. And we haven't even figured out one of the major ingredients of a really good healthcare system. And so it's kind of odd, no? But
Just for your information, my own experience with community health workers goes back to the early 70s when I lived in Mexico and had the opportunity to see the promotora movement and understand what it did for the healthcare system in Mexico. And so when I moved to Arizona, I was really, really fortunate to work with other people at the University of Arizona and in the community of Yuma, Arizona, to start the first promotora program in 1985 that's called Un Comienzo Sano, Health Start. Those of you who know it to this day. It is the only state-funded community health worker program in the state. And the funding comes from the lottery. That doesn't even come from our general budget. But at least we have one long-term community health worker program that is funded by the state. And after that program really blossomed, that was when the whole network of community health worker programs that you now saw in this panel, 5 minutes ago, developed all over the state, with some people working on cancer, some people working on diabetes, some people working on healthcare in general, et cetera, and weaving together the community health worker movement that we have in our state and joining forces with the CHR movement in this state. And it was in that year, in 2013, when you saw on Karen's little timeline there that, the Affordable Care Act had just passed in 2010, and it took forever for everybody to even figure out what it really meant. But all I knew was that a whole bunch of people kept saying to me, about 2,000 times in that 1,000-page piece of legislation are the words community health worker. And so everybody was going, well, if it's in there all over the place, maybe this is the time where we can figure out how to really integrate community health workers into our broader healthcare system. And so that's when we kind of started getting together and looking all around the state saying, how can we do this? How can we be part of this picture as allies and as community health workers themselves to really figure out a mechanism in the state that recognizes community health workers? And Flora, God bless her, went all over the state in 2014 talking to other community health workers and said to them, what do you want? Jill keeps saying it's 1,000 times written in the Affordable Care Act, it's community health workers. And the one thing that they said over and over again that Maya mentioned in the panel was, we want to be recognized. We're doing all this work and we want to be recognized. So perhaps the most important thing that voluntary certification does, way beyond, even though sustainability and reimbursement is incredibly important, is it says the state of Arizona recognizes the profession of community health workers. And that is really, really critical to any workforce. So don't forget, and I think Patty mentioned when she was talking about all the certifications that community health workers are getting and all the different kinds of trainings that are going on throughout the state, that with voluntary certification, it goes beyond any individual training that CHRs, the promotoras, et cetera, are getting. It's saying the state of Arizona recognizes you as a community health worker, and that community health workers are an existing profession that is important to our state. So don't forget that piece of it. Of course, the other piece is sustainability. And you saw how this morning we were all like one person after another saying, Access is here, ADHS is here. We got to talk to them. We got to make sure that they're on board for this piece. And so that's the other piece of it. And that's kind of what is happening right now. So we did all this stuff. We passed the legislation. The rules turned out to be much, much more difficult in terms of what was going to happen. As I mentioned a little while ago, it took 4 years to get these rules up, but let's not go backwards. We're going forward. We got the rules. They're almost done, and it is going to happen. I think our colleagues here from Access are going back with the message that we feel it's urgent that something really happen in terms of reimbursement. So, you know, they kind of know their little piece. And in addition to that, if COVID did nothing else in this country, it laid bare what's wrong with our healthcare system. And it showed how important community health workers are to this state. So it's like, this is our time, folks. This is the time for the allies, for all of us who have been supporting community health workers, to sit down with all of the community health workers in this state who are multiplying really fast in this state. Again, believe it or not, thanks to COVID money. You know, who would have expected that something so horrible as COVID has actually offered this opportunity for us to really get more training money into this state, really get more employment of community health workers into this state right at the time when voluntary certification is going to kind of come to fruition. So Jody asked in her thing, why are we here? And I sat there and thought, yep, why are we here? And where's Sam? Sam said, you know, we're going to do this and we're going to get together and we're going to make something happen. And I really believe it's up to all of us in this room. I mean, it's absolutely the time when Flora is going to talk about, this is your time as community health workers to talk to Access, to talk to the state, to talk to anybody, whether they want to listen to you or not, about what is important to be involved as reimbursement rolls out, because I'm confident that something will roll out. So every single person in this room has a role to play. And if it doesn't come out good, it's because we didn't make it happen. I mean, that's the reality of it. Everybody in this room is a player. That's why you came to this meeting. That's why you're on Zoom. And, you know, my son, who is a lobbyist in Washington, whenever I tell him, you know, I'm on the outside pushing in, and he said, well, that's what you all do. That's your job. And that is our job. That's our job, to really be sure that the people from Access know what community health workers want in this state. It's everybody's job in this room to know, be sure that ADHS knows what really wants to happen. And it's the Arizona Community Health Worker Association, which represents all the community health workers in the state, be they CHRs, be they promotores, be they outreach workers, whatever title they have, to bring that voice to the table and make sure over these next 3 or 4 months that are going to be critical, once those rules are up, you know, we're going to be knocking on everybody's door saying, let's get this going. And it's got to be all of us. It's got to be community health workers themselves. It's got to be us who are allies. It's got to be every one of the programs that we're sitting up here. It's got to be the CHR movement. It's got to be all of us, because that's the only way we're going to make this happen in the right way. And the future really is in community health workers. I mean, nobody in this room doesn't understand what community, if for some reason you weren't quite sure who holds the fabric of our communities together in terms of health and the health of our communities, we know that now. There isn't any other, there is no way that we can't say that. Who was on the front lines? I don't have to tell you all were there. You were on the front lines, and everybody saw it. Everybody realized community health workers are essential to the health, not only of our communities, to our state, to our nation, however big you want to make it. But that's where we got to go, and we got to go together. And so, Jody, I say we're here because we've got work to do in the next 3 months of making sure that everybody and anybody who has some influence in how this voluntary certification is going to roll out, that they hear from all of us. So those are my parting words to everybody, and I'm going to pass it on to Majoline, I think.
Good afternoon. My name is Majoline Begay, and I'm the former Navajo Nation CHR Program Director, and I am happy to join you virtually.
Where is she?
Sorry, I wish I was there with you in person, and it's good, so good to see all of you attending this conference in person. For the tribal members, I'm Ishin Twitchin, Ibashin, Hanagani, Dashinaldo, Ashkahatsa, Dashiche. As Native American, we always identify our identity through our clan system. And so with that, I want to say that as community health workers, promoters, CHRs, or community health representatives, we connect health and social care to improve the health outcome in our communities. We do that really well, and we unite our community people in need of care to health resources to improve their health, and also to empower them with resources that we lead them to, resources that we show them. And let's continue to move our profession forward. You can do that by taking your voices and advocacy to 3 levels. One is there in your own communities, and the other one is at the state level, and the third one is at the national level. So the local level is very important, and this is where you start your advocacy. This is where you start your voice as a CHW, CHR, and promoters. And this is also where you build your capacity to build on your skills, knowledge, and application. Tap into all the resources, tap into all of the training that's being offered. I know we send you a lot of information about various trainings. Please take in all those trainings. And don't limit yourself to being at one level. Try to work to advance yourself, move on to the next level. And I know, and I believe in you, that you can do it. You have done that at the community level, so let's also move you to the next higher level. And then continue to build on your leadership. Read more about leadership, community leadership, and you will never forget that. And with all those skills, knowledge, leadership that you build at your local community, you can take that on to the state level. And at the state level, when you do your advocacy, when you empower these legislatures about CHW profession, you can, there's no limit to how much knowledge you can instill onto these legislators who are our policymakers. You know the needs of the CHRs, you know the needs of the promoters, you know
Majoline, I think you went on mute.
and then also the service reimbursement, as well as the oral health. And so this is where you can really put your skills, knowledge to work. And you can take those on to the national level. At the national level, I urge you to join the American Public Health Association CHW section, as well as Association of Community Health Worker. these are the two national organizations where you can really build your leadership and where you can really exercise your advocacy for the CHW profession. And you can take that back into your community and run for some of these local political positions that can help you to strengthen the CHW profession. I believe in you and I know you can do that. And so I would like to see you making policies, passing legislation at those level and continue to support the CHW section. Thank you for having me as one of the speaker in this the closing section of this conference, and hope to meet you in person soon. Take care. Bye-bye. Have a good night.
Thank you, Maylene. Where is she gone? She's gone. What privilege do I have today to close the day after this amazing speakers panel before? What can I say? I got a piece of paper. I have 3 points. And when my friend Jill came over here, said, point 1, point 2, point 3. Jill, you got all my points. But okay, what can you talk about? Really about the workforce. One of the things that I want to first is acknowledge all of you for being here, for taking the time to come and listen, but also to learn and share your experiences around the CHW workforce. I want to acknowledge also my sisters, my colleagues, my friends, my amigas, CHW workforce. Can you all stand up here in the room? If you're a CHW, stand up, please. And when I say CHW, I include CHWs, CHRs, promotores, assisters, outreach workers, anybody that does outreach worker in their community that provides services to a community they live in. We are the community health workers. We are not working in silos anymore. We were working in silos before. Thank you. Can sit down. When we began working on uniting the workforce, it was really uniting the workforce. We began with the movement in 2001. Thank you, Jill. She invited me in 2001 to come to a meeting in Tucson. And I said, what are we gonna do there? Well, I'm a promotora. I was doing HIV education, STDs to the farmer population. What am I gonna do? What am I gonna share? What can I have of interest for others? When we came around the table, and it was like maybe 15 of us. And there was 2 ladies from the Hopi tribe, CHWs from Tucson area. We had promotoras from Yuma County and some Nogales as well. And we talked about, so we were a little bit shy and talking about what we do and start sharing. And it started like a little group of just sharing what we did, what worked, what didn't work. It was really around the chronic conditions that we were still just initiating working, because before the chronic condition, everybody knows that in the 80s was HIV STDs, the biggest things. So one of the things that happened is that as we started sharing and we started like, okay, should we like have a conversation again? Of course, that was a one-time meeting because there was not a lot of funding. Back then, still not a lot of funding to meet, but back then it was, can we have a call? It was conference calls. So we started calling ourselves and just meeting every month. And obviously, as still as we can see right now, there's not a lot of support for the CHW workforce when they're out there trying to do advocacy. We hire a lot of CHW personnel staff to do particular project, to go on and do specific deliverable based on grants or based on the programs that we have in our organization, health systems. But a lot of times we do not add program managers, supervisors, or
organizations see the value of educating and providing the capacity building and provided the training for the CHW workers to advocate for their own profession, to build their own leadership. We do not do that, and still we do not do that. So back then, we did not have the support of our supervisors, managers. So of course, slowly, you saw 15 start ceiling that fell, 2 fell here, another one fell here, and suddenly we were only 5 having those calls. And slowly, a couple of years later, we lost the 2 ladies from the Hopi tribe. And it was only 3 of us. We still continue with the movement. We still continue trying to do something. And we got some other promotoras, CHRs, other CHWs from the community that could come and join us. We started building a board and started trying to organize. It really was very challenging because of the lack of resources, the lack of support. Finally, we said, okay, let's adventure and do our annual meeting. In 2003, we did an annual meeting. We had like 30 individuals in the room, and for us, it was a complete success because we had 30 people talking about our workforce together. And was not only CHWs, we had researchers, our friends from, and you see them here, you see them at the table, our friends also from Phoenix area that were on ADHS before Karen came. There was Carmen, and Carmen was always very supportive. So we started building, but we moved to 2013 when we started thinking about, okay, around the nation, there's a lot of movement. A lot of states are doing this and that. What are we gonna do in Arizona? So there was an opportunity for me to get into my car and live in my car and travel around the state and meet with promotoras, CHRs, CHWs, organizations, and ask them, what do you see? How this profession can grow? What do you see the needs? What are the things that we need to put together? And also we did an assessment with the CHW workforce. I said, what do you want? And Jill talked about this. For us, of course, we always talk about the sustainability of the workforce, but of course, if you really look at the data that we have based on the survey, the majority, it doesn't matter. We use the umbrella term community health worker, so it doesn't matter what specialization I have. If I work with the promotoras with the Hispanic population, the CHR with the native tribes, or the community health worker with other communities, it doesn't really matter. Everybody said, I want the respect from my other colleagues at the clinic, at the organization. I want my supervisor to respect me as an employee and not seeing me as an aide that is really at the lower end of the organization. I don't want them to see me as I'm a volunteer all the time. I want to have the respect. So the respect was number 1. And for me, it was really like, yeah, we need to be respected, but we need to be recognized. I recently was participating in, there was a national meeting, international meeting around the CHW workforce around the world, global. And they were talking about counting the CHWs, building that registry. We in Arizona, we don't have a number of how many CHWs we have in our state. We use so many titles to identify the workforce that really limits our advocacy efforts that we have. It limits the unity that we can create. It limits the opportunity for us to continue growing a systematic profession that is strengthened every single day. I think that right now it's a perfect opportunity. Jill said, we're almost there. It has taken us so much time to put this together. And so many nights of not sleeping and just being so stressed because tomorrow I have to be testifying in front of all these individuals. They have poker faces. Have you seen where you're like talking to people and they don't move? And it's like, it was so stressing to talk to them and trying to get my point across. And I was like, oh my God, I'm gonna be testifying again. What am I gonna say? So it was very difficult, but I think it was worth it. I've always known that the CHW workforce relies and trusts the Arizona Community Health Workers Association, which we represent. So I always know that when I stand, I carry the voices of all my hermanas, my sister, my colleagues, my friends, my amigas. When I talk, I need to make sure that I represent them well. That I'm always looking, how do we grow this organization? Not because I think we need to do that, but because we all want it to be that. We have this perfect opportunity now. I don't know how long it's gonna take for us to get that voluntary certification open, but I'm already there in the list. I wanna be there. I wanna make sure that we test pilot, that this is what we have been fighting for. We have been advocating for. We know that we can sustain the associations, the organizations, the programs at community level, our system levels, we can sustain them. We have reimbursement. We have a way to really provide. The data, we have it. We can ask our friends, we have the data. That we can prove that we need the CHWs. Now it's our turn to come together, to work together, to organize, to strengthen. We've always been working in silos, I said at the beginning. Silos, not only an organization, at community, at individual, we didn't used to share. But now we're still working in silos. There's systems in place in our state that are still working in silos. There's so much information that we can provide you that are making the decisions. Ask us. Don't go again and reinvent things when we have the information we can provide you to make the right and the best decision for whatever you're going to be putting together. We have the experience, we have the capacity, but we need to work together to do that. And we cannot continue working in silos. There's only one state and there's only one workforce, and that's the community health workers. And we have made a difference and we have seen it. And COVID really brought it in a place that was at front and center. We know how CHW responded. We know how CHW did not have the protective equipment. And we know that we lost many CHWs through the process. We are moving forward. We are building networks. We are building collaborations. And we will continue providing that capacity building. We'll continue developing the trainings to continue strengthening the workforce, because our workforce is vital to our healthcare in Arizona. We need to continue working together to continue to make sure that it's a sustainable professional workforce. Thank you for being here today. Thank you for everything that you do, and let's work together to make this happen soon. Thank you.
Thank you all for coming, and thank you for staying over just a little bit more time. This will allow for you not to hit the traffic, maybe, if that's what's going to happen. Thank you all for coming, and we will send out an evaluation. And with that evaluation, we'll send all of the ways that you can become involved. We'll give you the emails and all the good links. And we've taken note of all of the kind of mentionings of different resources throughout the day that we'll compile and put together. Thank you again to all of our presenters and our moderators and all of you as participants in today. And thank you for all of you that are online. We appreciate you, and safe travels going home. And we'll see you all soon. Thank you.